We are on the record at 10:01 a.m. on February 4th, 2025. This is a Zoom recording of Dr. Yong Lee. The court reporter is Bonnie Smith. Will counsel please introduce themselves and state any objection to the witness being sworn in remotely?
James Potts, no objection.
Spencer Bomar here for Dr. Lee and OrthoAtlanta. No objection.
Olivia Beckett here for Piedmont Orthopedics. No objection.
All right, Dr. Lee, would you raise your right hand? Do you swear the testimony you're about to give in this cause to be the truth, the whole truth, and nothing but the truth?
I do.
Thank you.
Would you please state your full name?
Yong Lee.
Will you spell that, please?
Yong is my first name. Suk is middle name. Lee is last name.
Where do you live?
I did.
And do you have email addresses that you use for your work?
My work email address.
Thank you. Do you also have a Piedmont Healthcare email address?
None that I'm aware of.
All right. And are you affiliated with any healthcare organizations, hospitals, surgery centers?
Yes. You would have to contact our credentialing, but the way that would work is I am, say the question one more time so I can answer it to the best.
Sure. I mean, your affiliations with healthcare organizations, do you mind sharing those with me?
No, I don't mind.
All right. What are those?
It would be the Austell Surgical Center. It would be, at that time, Wellstar Health Systems. It would have been the Paulding Hospital. And I don't believe I was staffed at Piedmont at that time. I may have been. I would have to check that record.
All right. I'm going to show you what's been marked as Exhibit 1 to your deposition. And the way I'm going to do this is there's a chat. I don't know if you can see it on the machine you're looking at, but I'm going to upload the document there where you can open it, print it, do whatever you like with it. And if you need time to do that, please let me know. And it's not an issue at all. I'm also going to open it on my screen. I work from notebooks, even in my office, so my screen's not that large. If there's a portion you can't see, have trouble seeing, if you need the document enlarged, I'm happy to do that. So just let me know about that. All right?
Okay.
I'm going to show you what's been previously marked as Exhibit 1 to your deposition. And that was provided to us over the course of this case.
Yes.
And does that accurately reflect your education, training, and experience? I'm scrolling through that, and we can walk through this far more slowly if you like.
Okay, to start with the top, I want you to understand that that was the correct address at that time. I have since gone to Cartersville in
Yes,
case
sir.
that's the discrepancy.
And this accurately describes your education, training, and experience,
Yes,
and your work experience.
yes,
And it reads here that under your work experience that you worked with Piedmont Orthopedics, LLC, right?
yes,
And also OrthoAtlanta, LLC. You see that?
yes, I do.
And you've been at OrthoAtlanta, LLC since January 2015, right?
Yes,
To present.
correct.
Same Piedmont Orthopedics, LLC, February 2020 to present.
Yes,
You were employed by both Piedmont Orthopedics LLC and OrthoAtlanta LLC in June 2022, right?
I worked at both. My employer is OrthoAtlanta.
All right. You work to work at a place, you have to be either employed there or an independent contractor there. Does that make, you agree with that?
Expect a form to extent it calls for a legal analysis, but go ahead and answer if you can.
I don't understand the question. My
Sure.
employer, as I understand it, is OrthoAtlanta, and we have a corporate working relationship with Piedmont Orthopedics in the form of a physician services agreement.
All right. So you were employed at OrthoAtlanta, and by the physician services agreement, you also performed work at Piedmont Orthopedics LLC. Is that right?
Yes,
Have your hospital privileges ever been diminished in any way?
no,
Right. And have you ever given a deposition?
not of this type.
All right. Of what type depositions have you given?
Expert witness,
All right. Any others?
none that I can recall.
All right. And when you testified as an expert witness, was that on behalf of a physician or a patient?
I think it was on behalf of an insurance company.
Okay. Do you remember the name of the insurance company?
No, I do not.
You remember the nature of that case?
No, I do not. May have
What
been
year did
20
you testify? I apologize.
I apologize.
No, that's
It
all
was
right.
several years ago, and in my 28 plus year career, I have maybe given a total of 2 or 3 depositions regarding things such as motor vehicle injury or work injury.
Okay. And the one with where there was an insurance company involved, do you recall what county, what court that was in?
I do not. It was many
And-
years ago.
Yes, sir. And was that in the 2020s, between 2010 and 2020, if you have any idea? And if you don't know,
I don't know.
all right. Now you understand that your deposition is a public document,
Yes,
can be shared with other physicians.
sure, if you're telling
Sure.
me so. I would agree with your statement. Thank you for
All right.
your education on the matter.
Yes, sir. It can be shared with your work colleagues.
Okay, thank you again for letting me know.
You're welcome. It can be shared with nurse practitioners, PAs, nurses that you work with.
Thank you. Yes,
Can be shared with the Georgia Medical Board.
okay.
And you're board certified, right?
Yes, I am.
And you're board certified in what?
Physical medicine and rehabilitation by the American Academy of Physical Medicine and Rehabilitation.
And that and you're an MD or a DO?
I have a medical degree from a medical school.
Yes, sir. And is your board certification provided by a physician's board?
Yes,
Have you ever consented to a medical malpractice settlement?
No,
You are aware that an improper epidural injection can lead to a catastrophic injury?
yes,
You agree there are policies and procedures exist to prevent an injection into the cerebrospinal fluid when you're performing a cervical epidural steroid injection?
I am.
You agree?
I agree.
Yeah.
I thought you said am I aware? And so I answered it, I am, instead of I agree.
Well, I misspoke then. You agree that there are policies and procedures that exist to prevent, in the course of a cervical epidural steroid injection, injecting the patient in the cerebral spinal fluid?
To that, I would say I agree.
You agree that a misplaced cervical epidural injection would be a breach of the standard of care?
I disagree.
Okay. Did you bring any documents with you to your deposition today?
Few,
All right. Well, what documents did you bring?
the download of the medical records from our practice.
All right.
Also, the surgical notes from the surgical center of that day.
So that's surgical, your surgical note?
That's part of that document, yes.
Okay. Any others?
No,
All right. I'd like to mark those, what you brought today, as Exhibit 2. You can upload that at your convenience. And you said those are medical records downloaded from your, I guess, OrthoAtlanta, Austell, and surgical notes, right?
I don't think so. I think it would have been from OrthoAtlanta Hiram office, not Austell. The surgical center is located in Austell.
Okay. So these documents would have been kept in Hiram as opposed to Austell?
The documents I'm referring to are EMR documents. I think they're housed on the web. But the location for which the document was created at the time would have been my Hiram office, as well as the Austell Surgical Center on the day of service.
And by EMR, you mean electronic medical record? Sorry.
Yes, that's what I mean.
Now, you performed a cervical epidural injection on Miss Arlena Addison.
I've done several.
You've done several cervical epidural steroid injections.
That is correct.
You performed one on June 9th, 2022.
I have that in my records.
Yes, sir. And I appreciate your answer. My question's a little different.
Okay.
You performed a cervical epidural steroid injection on Arlena Addison on June 9, 2022.
I did.
And that was between 10:24 and 10:34 in the morning.
I believe that's correct.
And that was in the operating room.
The procedural suite.
Okay, procedure room.
Yes.
And the procedure room is where the C-arm is located
Yes.
in June 2022.
Yes.
It was in that room, right?
Yes.
That was at the OrthoAtlanta Surgery Center
Yes.
in Austell, Georgia.
Yes.
And prior to the procedure, you ordered Bursid. for Miss
I
Addison?
did. I did.
Prior to that procedure, you also ordered fentanyl for Miss Addison,
I did.
and you administered Versed.
Under my orders, the nursing staff did.
And you also administered fentanyl.
Yes.
You were the attending physician responsible for Miss Addison's care that day.
Yes.
You were responsible for ensuring the procedure was done safely
Yes.
and properly.
Yes.
You have heard the phrase, do no harm.
Yes.
You agree that the safety of your patient is of paramount importance.
I do agree.
There's nothing more important than that, right?
Nothing more important.
And you agree that when you care for a patient, your first order of business is to do no harm.
Yes.
And part of your responsibility is ensuring that proper imaging was documented.
I agree.
You agree that there are standards of care applicable to epidural steroid injections,
I agree.
just like the one you performed on Arlena Addison on June 9, 2022.
Yes.
And you agree that the standard of care requires real-time fluoroscopic imaging
I do.
during the cervical epidural injection?
Yes.
And you agree that CESI stands for cervical epidural steroid injection?
I do.
And we can use CESI for what you performed on June 9, 2022?
I'm comfortable with that.
All right. And the fluoroscopy is an X-ray.
A live X-ray that has video capability.
It's a live X-ray, right?
Agreed. In layman's term, at least in my mind, a X-ray is a one-time photo, where fluoroscopy is a pedal that you push to allow for real-time movement of the image in question.
All right. So the best phrase for it is real-time X-rays.
That makes more sense to me.
Okay. And it also allows you to observe movement in those X-rays,
Yes.
as opposed to a static single film, as you suggested.
Yes. If the pedal is held down, you will see movement.
And you're talking about the pedal that's part of the fluoroscopy machine?
Yes, correct.
You're aware that there are also, instead of using an X-ray, another way to observe real time what's happening in the course of a cervical epidural steroid injection is a CT. Is that right?
I'm aware of such a thing, yes.
Those have been around for a long time, many years, right?
I couldn't tell you when they first started. I
Yes,
don't.
sir. My question was whether you could tell me when they first started. You're aware that CTs have been around for many years, right?
Yes,
And that CTs have been in use in the performance of a cervical epidural steroid injection for many years.
I'm not aware of that.
Okay.
My awareness is that it is uncommon to do the procedure using a CT scan. There are uses of CT scan for procedural interventions, such things as lung biopsy, liver biopsy. The inherent nature of that machine being large, bulky, in a procedural suite makes it extremely uncommon to perform a cervical epidural steroid injection using a CT scanner machine.
Right, and you've never used one.
No, I'm not trained in that.
All right. You agree that when you're performing a cervical epidural steroid injection using real-time fluoroscopic imaging, that you need at least 2 views?
I don't agree with that.
Okay. It's your testimony that a single view will enable proper needle placement?
It is.
And you're not required then to have both an AP and a lateral view, right?
It's not a requirement for the standard of care in my community.
All right. And I'd like you to cite for me any treatise, any textbook, any chapter in a textbook, any peer-reviewed article, non-peer-reviewed article, grand rounds, throwaways, anything, any medical literature at all that suggests a single view is within the standard of care.
I would have to get back to you on that. I do know that local practitioners in my community use single view.
All right. And you agree that real-time fluoroscopic imaging during the course of a cervical epidural injection also requires contrast dye?
For confirmation of placement, contrast dye should be applied. Yes,
And according to the medical record, you used a contrast dye,
yes, I did.
Omnipaque.
Yes, that's the brand name of the dye.
Yes, sir. And you use that to confirm correct needle placement
I did.
prior to injecting drugs into Arlena Addison.
Yes, I did.
You agree that the standard of care requires you to document that?
I do.
You agree that the standard of care also requires that you document the contrast flow
Yes,
to confer proper needle placement?
agree.
And the contrast agent that you used according to the medical record, Omnipaque, is used to verify needle positioning before you inject anything into Arlena Addison,
Agree.
including drugs, right?
Agree.
And the contrast should be visible on the fluoroscopy image, right?
Agree.
If it's properly administered.
Agree.
You agree precise needle placement is required when you're performing a cervical epidural steroid injection?
It's very important. Yes.
It's required by the standard of care.
Yes.
And one reason is because the epidural space in your cervical spine is small,
Agree.
quite small,
Agree.
between 2 and 5 millimeters.
I don't have a citation, but in general, I would agree.
And a female patient that weighs about 115 pounds, it would be closer to 2 millimeters than the 5 millimeters typically.
Disagree. Everyone's unique and different. It does not depend on weight.
You agree that 2 millimeters is about the edge of a nickel? You see that all right?
I can see that.
I'm trying to get it on my camera.
Yeah.
Does that appear to be about 2 millimeters?
Okay. Agree.
when you're performing a cervical epidural steroid injection like you did on Arlena Addison on June 9, 2022, you're only 2 to 5 millimeters from the cerebral spinal fluid.
From the dural sac, which encases the cerebral spinal fluid.
Right? You agree with that?
There is a small distance between that, the epidural space and where the dural sac starts.
And that small distance is about the width of the edge of a nickel.
It varies in individuals and it is not dependent upon their weight.
Okay. Well, it's between, according to medical literature, it's between the width of a nickel and the width of 2 nickels, right?
Okay, fair. Agree.
And you agree that injecting drugs into your patient's cerebral spinal fluid can cause catastrophic injuries.
If that were the case, yes.
As a result, precise needle placement is required.
To minimize chance of complication, yes.
And the standard of care requires that.
To accurately place the needle at correct depth, it does.
Well, yeah, correct depth and placement laterally, right?
Placement laterally. Can you expand?
Sure. I mean, you could have the needle at the right depth and in the wrong place.
Possible.
You want to be both in the right place and at the right depth, right?
To me, the right depth is part of correct placement.
Right. Part of it. The other part is being in the right place.
Fair. Yes. Yeah, I can agree to that.
You agree that needle misplacement is a well-known risk in a CESI?
Yes, I think that's why consents are given to patients. It is a possibility.
A consent, a consent
To
to the
perform
risk of the
procedure.
procedure?
Yes.
Right.
Yes,
You agree that that consent doesn't excuse a doctor from malpractice, right?
agree.
Now, some folks get that confused, but you're not confused about that, right?
Oh, no. Ask that first question again, please, so I make sure that I understand what you said.
Sure, the consent to the
No,
risk.
before the consent question, you asked a question and it prompted me to use the term consent.
Hell, I don't remember. Madam Court Reporter, do you have the question, I guess, before last?
Give me 1 second.
Thank you.
Question, you agree that needle placement is a, hang on, let me see. You agree that needle misplacement is a well-known risk in a CESI.
And that's what prompted me to say consent. Yes, I agree, because that is covered in a consent. That's what I was getting at.
All right. Yeah, and when you answer questions, you can use, I mean, whatever you like to answer the question as best you can. It's no issue with you saying consent in the answer to that question. I'm not sure.
Okay.
Okay, yeah, not a problem. I was
don't
just
take it
following
as-
up. I was following up based on your answer. That's all.
I see. Thank you.
Yes, sir. And I think let's see. You do not agree that the standard of care requires at least 2 fluoroscopic views to confirm placement, right? You said in your community, 1 is enough.
Correct. I did make that statement.
You agree that you're also required to document the contrast spread before you inject anything into your patient?
Yes,
And by that, I mean confirmation that the contrast dye spreads properly.
agree.
And the contrast dye, depending on whether you're in the epidural space or the cerebral spinal fluid, the spreads would be different, right?
On most occasions, yes.
And if you're in the proper place, it'll spread definitively.
It will spread in a pattern that I can recognize to ensure my level of confidence for correct placement.
It'll spread in such a
Definitively,
way
I
that you
don't
can
know
see
that.
the spinal. Go ahead. I'm sorry.
Definitively, I'm just not comfortable with that word. That's what I'm.
All right. Let me see if I can do a better job of my question. You
Okay,
agree that if the contrast dye is in the right place, you can see the spinal structures?
I can see a spread and flow of dye.
Well,
I
and
can't
how
see a
would you
spinal structure. I cannot see a spinal structure. It's a dye.
how would you describe what you see when? How would you describe the contrast dye flow when you're in the proper place?
A thin film of gray material.
So a thin gray line, is that right?
No, material, blob isn't the right word either. It's just a small area of spread from the tip of the needle onto the surface. So, sorry, I can't do better. Spread, small spread of thin gray material, radio opaque material.
And it would spread around the structures.
It
Right.
would, but I cannot identify the structure.
Well, but you got to identify that it's spreading around the spinal structures, right?
Yes,
As
I
opposed
cannot make
to,
out the structure itself. I cannot make out the structure.
all right. As opposed to if you're in the cerebral spinal fluid, there would not be a definitive spread like that, or there would not be the descriptive spread.
It would be less so. Less so is the word I would use. Because there's still dye. The dye is still in the body and blocking the X-ray from penetrating.
All right. You agree that before performing a cervical epidural steroid injection, your patient also has to be able to properly respond to pain?
Oh, yes.
And that's to ensure your patient's safety, right?
Improve upon, yes. Maximize safety. Maximize safety. That's my understanding.
Yeah, do what you can to maximize your.
That's right. Yes, yes.
All right. You agree that you inject contrast dye while using fluoroscopy, the real-time X-ray, to visualize the spread of the dye in the epidural space, right?
Yes.
And if the needle is properly placed in the epidural space, the contrast dye will spread in a smooth linear pattern along the spinal canal.
Along the ligamentum flavor. Yes, within the spinal canal. Okay.
And if the needle is in the cerebral spinal fluid and CSF, we can use CSF for that.
Yes, I know that term.
CSF, the contrast will quickly disperse in an unpredictable pattern indicating a misplaced injection.
That is typical.
All right. You agree if contrast dye does not appear, the needle placement is unknown.
Yes,
And if contrast does not appear, you must not proceed with the injection.
yes, in this particular case, contrast dye did appear and it was static and I saw it. I used a very small amount. I prefer to use small amounts to minimize any potential complication. There was contrast dye applied. I did use the fluoroscopic pedal. I did see what in my clinical judgment was appropriate spread and flow of the dye,
And
utilizing one view.
you didn't.
Utilizing the one view.
What's that?
Utilizing the one view. I did see from the AP picture a flow of contrast dye that was consistent with proper placement.
And the one view was from you called it the AP. Explain what you mean by that.
Anterior to posterior,
Okay, as opposed to lateral.
correct.
So the one AP view with the dye is what you use to properly place the needle.
Along with needle depth gauge using a loss of resistance glass syringe.
And loss of resistant glass syringe you use how?
It is connected to the procedural needle. There is a column of air and it is gently pushed upon by the plunger as the needle is slowly advanced. Depending on where the needle tip is, various degrees of resistance will occur, starting from the skin, through the subcutaneous fat, through the muscle layer, and then onto the ligamentum flavum. The ligamentum flavum is a type of soft tissue that is probably a cousin to a tendon, a ligament, like gristle. It's firmer than is muscle. And when the tip of the needle approaches, resistance will increase. And with slow further advancement of the needle, once the needle tip pierces through the ligamentum flavum, it enters into the epidural sac. The epidural space. The epidural space is the space that surrounds the dural sac. It is that space that has negative pressure. So by slowly advancing a needle with a glass syringe under gentle pressure, when the glass syringe plunger drops, then the tip of the needle has pierced the ligamentum flavum and is appropriately placed into the epidural space. That is how depth is judged.
It's pushed by you, the physician, right?
Yes, I was the operator.
You agree if contrast does not appear, the needle placement is unknown, right?
Yes,
And Miss Addison's case, only one fluoroscopic image was saved. Is that right?
from my review of records, yes.
And that one image does not show contrast dye.
It does. I have reviewed that image and I do see dye flow.
All right. You're not a radiologist, right?
Nope,
You're training in radiology?
not formal, just what they teach us in my residency.
When was your residency?
It was at Emory University, 1992 to 1996.
So that was 92 to 96, about 30 years ago. Is that right?
Close to it.
Yes, sir.
I think it'd be 26 before 30 came.
All right. The image we'll get to in a bit is marked in the lower left corner, number 2. Is that right? Do you recall?
James, do you mind putting that up on the screen so you can look at it?
Well,
Or
we're
I-
gonna-
I've
Yeah,
got
go
a photo of it here if you want me to put it in front of him.
if he doesn't remember, we'll get to it in a bit.
Okay.
You don't recall the image, is that right?
I wouldn't say that. I have in preparation seen the image, so I have recollection of it, not from 2022, but yeah, I've seen it.
And based on that image, you proceeded with the injection,
I did.
Lena Addison?
Yes, yes. In that patient, yes.
And you documented that the procedure was performed properly?
I did.
And that image is your proof of proper needle placement?
Proof, yes. We can go with that.
I believe I already asked you whether you could cite for me any literature about a single AP view indicating proper placement. You said you didn't remember any or didn't know of any. Have you since thought of anything that might help with that?
No, none beside that the standard of care in my community are physicians that use single view along with glass syringe, loss of resistance technique to gain proper depth.
Now, another name for Versed is midazolam. Is that right?
Yes,
And you administered midazolam before the injection?
I did.
That's a benzodiazepine,
Agreed.
and it works as a sedative, sedates the patient.
Anxiolytic. It
What?
has some anxiolytic. It cuts down on anxiety.
Also sedation.
Mild sedative effect. Agreed.
You agree that midazolam impairs a patient's ability to respond to pain?
In escalating doses, that can occur. In properly administered doses, that side effect is minimized.
All right. You also administered fentanyl
Agree.
before the injection,
I did.
and fentanyl is an opioid,
It is.
a narcotic.
Agree.
Fentanyl also impairs a patient's ability to respond to pain.
Diminishes.
Diminishes, is that right?
Diminishes. Yeah,
You agree the standard of care requires an alert patient
I
to
do.
detect pain?
I do. Sorry to cut you off.
That's all right. The standard of care requires you have an alert patient when you're performing a cervical epidural steroid injection.
I agree.
And I'm sure you've had patients cry out in pain when you begin an epidural injection.
They express ascribe to cry out in pain. I don't ascribe to that. Patients would express discomfort,
And how would they express discomfort?
moaning or ow, or I feel that, like that. Words. They would say words.
Not something like, ah, no, nothing like that.
Not typically. No.
Miss Addison was sedated at the time of your injection.
She was appropriately sedated, yes.
She was less able to react to improper needle placement.
Disagree. She,
Are you looking at something to your right?
no, I'm not. I'm playing with a pen.
Right. Who's in the room with you?
My attorney,
Okay. Anyone else?
no.
You discussed this case with anyone else?
Besides my attorneys, no.
Now, I didn't see in your note where you recorded that Miss Addison had any sort of reaction to pain.
Agreed. She was comfortable throughout the procedure. She was awake, alert, and conversive throughout the procedure and did not display discomfort. Did you call it crying out? No, she did not cry out, nor did she express any other form of discomfort, but she was awake, alert, and conversive throughout the procedure. I typically talk to patients throughout the procedure. That is my standard.
Yes, sir. And you administered Versed to Arlena Addison twice.
She may have gotten to a verse that, sure, whatever the records show, I would agree to that. That's the reason for documenting.
You ever heard the phrase "not documented means not done"?
I think so in the course of all of this. Before that, probably not.
Okay. You agree medical records are important
Absolutely.
and they're important for the safety of your patient?
Yes.
Now, Miss Addison started showing symptoms at around 10:34 that morning.
I need more detail. What does that mean, started showing symptoms? Could you elaborate?
Sure. In your note, you said that Arlena Addison started showing symptoms, including decerebrate posturing. Do you remember that?
Yes, I do.
And that was around 10:34 that morning?
If that is a timestamp, I would agree. If I may, I performed the procedure. It went without complication. I turned, as I typically do, to begin the process of cleaning out my procedural tray. And it was during that time the nursing staff routinely would move the patient from a prone position on the procedural table and flip them over to supine on their back. That all occurred without incident. It was the same as the previous 3 cervical epidural steroid injections she had with me. This was routine. Nothing was out of the ordinary. And while she was lying on the stretcher, the nursing staff, who was focused on her the entire time, noticed that she began showing that type of posturing, at which time I immediately turned to witness and see that she was in that position, and I appropriately documented that.
And how long have you been doing? I'm sorry. Were you?
You broke up.
How long have you been doing epidural injections?
28 plus years, from 96 until, well, let's do the math between 2022 and 1996, because now we're in 2025, so we'll have to add an additional 3 years. I'm still doing them, in other words.
And you've been doing them since when?
Since residency, 1996. Let's put that as a start date of moving toward the private practice world.
So 28, 29 years?
28, we can go with 28.
Okay. And you've been doing cervical epidural steroid injections for 28 years?
Agree.
And in those 28 years, how many times have you had patients exhibit decerebrate posturing?
0 before this case.
You agree decerebrate posturing is a potential sign or symptom of a severe brain injury?
When you ask me to agree and then you use the word potential, it's not definitive for it, but it is a possibility. So when you use the word potential, yes, such things can occur in brain trauma.
Decerebrate posturing is a sign of a brain injury.
I'm not a neurologist, I'm not a neurosurgeon, but as a yes, we are trained to look for these clinical presentations during my training in performing the cervical epidural steroid injection. If such a display occurs, then you are alerted that something may have went awry and that further higher level of care is indicated. I would state that.
And thank you.
Okay.
Madam Court Reporter, would you read back my question, please?
Decerebral posturing is a sign of a brain injury.
Do you want him to answer it again?
I don't think he answered it.
I'll just object to form asked and answered, but if you'd like to answer again, you can.
Would you answer that question, please?
I would best characterize it as a form of brain stimulation. I can give an example if you would like.
So it's your testimony that decerebrate posturing is a sign of brain stimulation, right?
Yes, yes, that would be an irritant, a brain irritant stimulation, yes. And again, I can give example.
And cite for me any treatise, textbook, chapter in a textbook, peer-reviewed article, non-peer-reviewed article, grand rounds, throwaways, anything in the history of medical literature that you can point me to that reads decerebrate posturing is a sign of brain stimulation.
Sure. For example, if someone has known pre-existing seizure disorder, they don't have a traumatic brain injury per se. They just have a miscommunication of the central nervous system and no traumatic injury occurred to them. Someone who did not receive a traumatic injury and has a seizure can develop such posturing temporarily. That is known. Another example would be the famous Miami Dolphins football player, Tua Tagovailoa. He was seen getting tackled hard to the ground, and he displayed similar abnormal posturing. He was found to have a head concussion. There was not injury to the brain, but there was stimulation due to the concussion that caused the abnormal posturing. And after 6 weeks, he has returned to NFL play.
You finished?
Uh-huh.
I didn't see, you agree that as a physician, you know what a history is, right?
Yes,
You take your patient's history, right?
I do.
I didn't see anywhere in your medical record any history of seizures in Arlena Addison. Did I miss that?
No, I'm not saying that a seizure was the reason for her posturing. That's not what I'm getting at all. again, I'm struggling to understand your terminology. What my testimony would be that it is entirely possible that when the glass syringe dropped, a small air bubble developed, and it may have been subdural. That air bubble may have traversed up to the skull, and the air bubble in and of itself was mechanical pressure to cause the activity that was identified.
You testified when we were talking about decerebral posturing just a moment ago that it's a sign or symptom. You know the difference in a sign or a symptom, right?
I do.
It's a sign or a symptom that something went awry, number one, and number two, a higher level of care is required, right?
Sure.
And something going awry in the setting of Miss Addison's cervical epidural steroid injection would include the possibility that there was an injection into her cerebral spinal fluid, and that caused her decerebral posturing.
It's within possibility, sure, yes.
And
Sorry.
that's all right. And that
I would like to say the following. Again, if you follow through with the procedure, and as you was alluding to, we talked about this already, the needle tip would be placed through the ligamentum flavum to the area that you described as 5 millimeters, 2 nickels, did you say? Somewhere in there
I
between.
said 2 to
1 and
5
2.
millimeters.
Yeah,
Yeah.
okay, yeah, I would agree. I just wanted to refresh.
You
Between
did.
2 and 5 millimeters. So what I'm trying to get at is if the needle tip were to go into the epidural space and then, unbeknownst to me, nick the thecal sac, then the next step in the process, as I told you, was to use a glass.
I lost you.
He's frozen on my end.
Yeah, mine too.
Shall I go through?
By me
You hear
telling
me,
you the
Spencer?
process as a column of errors.
Yeah, we lost you on that on that one. So if you want to begin again.
Can you hear us now?
Yeah, I can now, but he froze like at the.
Okay, so you might want to start your answer over.
Where would you like me to restart, sir?
Well, I don't. Do you know, Bonnie, where he left off?
Let's see. So the last sentence I had was, so what I'm trying to get at is if the needle tip were to go into the epidural space and then unbeknownst to me and nick the thecal sac, then the next step in the process, as I told you, was to use a glass, and then it ended.
A glass syringe, which contains the column of air to assess appropriate depth. So the first thing that may have been introduced into the subdural space would have been the column of air. And that column of air, after a period of time, could travel to the brain area and result in that stimulation. It could be as benign as a column of air. I am not saying that a column of air is completely benign. I'm saying that stepwise, the first physical thing that could have stimulated the brain to cause that posturing would have been the column of air. That's what I'm getting at.
All right, we're going to take a short break, 5-10 minutes. Do you have a preference, Spencer?
Either one, whatever you want.
All right, 5-10 minutes. We'll be back.
We're back on the record at 11:14.
Did you speak with anyone about your deposition over the break?
Yes,
Who'd you speak with?
my attorney.
Anyone else?
No,
You testified before the break that in your training, you recall being trained to recognize neurologic events after you perform a cervical epidural steroid injection, right?
that is part of the training. Agreed.
Yeah. And you testified a moment ago that decerebrate posturing, and you learned in your training two things. One, it indicated that something went awry.
Yes,
And two, that a higher level of care was required, right?
yes,
And the something going awry would include an injection into the cerebral spinal fluid that went to the brain and caused a brain bleed, right? That's one possibility.
yes, yes, it is one possibility.
And you agree that that would require a higher level of care.
I do.
And by higher level, that means someone with additional different training, right?
Yes, yes.
Someone, I think you mentioned a neurologist or neurosurgeon, right?
Agree with that.
And you agree that a hospital emergency department and hospital inpatient services provide something entirely different from the PACU at your surgery center.
Agree.
Higher level of care. Yes.
Different type of care. I mean, so if I were to replay the events in my head, I think we both said the same thing. When I recognized that posturing, there was, as I put it, an insult or stimulation of the brain to cause that posturing. With that posturing does come things like elevation of heart rate or breathing. She was noted to have those things. So in terms of what we did when I noticed that, of course, that differential went through my brain, and promptly she was taken back to the PACU area where she got appropriate and immediate care to address the current presentation.
You agree that that insult to her brain could be the administration into her cerebral spinal fluid of drugs?
Or air or contrast. Those items were all used. It may have. So.
Well, it would include drugs or air or
Yes.
saline or contrast
Agreed.
or any combination of the above, right?
Yes, yes. But so here's the other thing. You go and we agreed that the accurate needle placement is paramount. So the needle, and you said, and I agreed with, the several millimeters. So the needle tip may have nicked the sac. It may have actually come back to the epidural. In other words, those few millimeters, when a needle is in the back of the neck, it is actually fairly important to give sedation so the patient doesn't move and say ouch and flinch, because you yourself said it's a matter of millimeters. So yes, the patient needs to be appropriately sedated so they don't flinch and move, and the tip of the needle doesn't go further than it was intended to do. So that's very important, to give appropriate amounts of sedation, because that could occur. Like you were saying, I think you said the I forgot what you said. I apologize. You said cry out. I think that was the word you used. Cry out. Like, so yeah, if somebody cries out, in my mind, I'm thinking that they're maybe like, twisting their neck or moving their head. And that's like not a good thing when a needle tip is within millimeters of the dural sac. So yes, but my point being is that the needle tip may have nicked the sac. That nick, whether the tip of the needle was thereafter appropriately placed above the dura or continued to stay in the defect of the thecal sac and the medications were injected intradural or extradural, is a matter of millimeters. That's what I'm trying to get at. And so you're asking me, would I agree with what was injected? My answer is, let's agree that starting with the air, the contrast, the medication, and the saline, any of those things could have happened. But because we're dealing with tight tolerances with inside of millimeters, at any given time, it could have been a nick in the sac. The needle tip may have retracted to be into the epidural space. The needle tip may have stayed through the dural sac, and those items may have been delivered. But I cannot tell you which items were delivered where. That I cannot do.
Yes, sir. So your testimony is that the most reasonable explanation for what happened to Arlena Addison is that the needle may have nicked the sac, yet the drugs, saline, dye, were actually injected into the subdural space outside the sac, but
That
still.
would be the epidural space. That would be the correct. It may have been subdural. It may have been. So you're asking me to agree something I don't know exactly what happened is what I'm saying. All I'm saying.
Right, you were, I think you said explanation. Well, that's a likely explanation.
Fair enough. Yes. I don't know that there's more than one explanation, but so I don't know that I'm going to agree to what you're saying, but I'm telling you from my point of view in my brain that that needle tip could have nicked the sac, medication could have been placed, some of the medication could have extravasated through the nick. It could have been air, it could have been any of those things, the materials that we discussed. Yes.
You agree that bubbles go up?
I do agree. I do agree.
Air rises, right?
Yes, yes.
And if the patient's in a, what do you call it, a prone position or lying
On their belly, prone.
if the air is injected into the epidural space as opposed to where the cerebral spinal fluid is, that air would go up toward her back, right? As opposed
Yeah,
to
it would
down
be,
and up toward her brain, right?
my understanding is a little bit different than yours. So to answer your question the best I know how, if the column of air goes into the epidural space, as I told you, the epidural space has slightly negative pressure. So when a column of air is released into the epidural space, that is done safely. I'm not aware of complications occurring from releasing air appropriately into the epi on top of the dural space. So if the needle tip were to puncture the dura, now we're talking subdural. Do we have our terminology correct? Okay. So if it were if the needle tip were to advance and pierce the sac, then now we're talking subdural at that point.
And when you say sac, you're talking about the sac that houses the cerebral spinal fluid,
Yes,
brain, and the spinal cord, right?
yes, it's called the dural sac. The word is dura. So then when we start using terminology like epidural, that means on top of. And when we're using subdural, it means that inside of the sac. Now we have our terminology correct.
Yeah, well, epi would mean around, right? Not on top.
Well, no, in medicine, we call it on top of and around. We do.
All right.
Yeah.
So epidural.
Latin training is probably different. You know, you in law, me in medicine, maybe our training on Latin is a little different, but we use it on top of and around.
All right. So with a nick in the sac and the air drugs and saline on top of
Uh-huh.
the sac that
Uh-huh.
still could have made its way into the sac and traveled up to the brain and caused the injuries that Arlena.
Agree. Now I agree. Yes. I don't know. I don't have a microscopic view of what happened. I don't know what was in there. I used the standard of care, which was to get an AP image to make sure that my needle tip was not too high, not too low, not too left, not too right. Simultaneously, I had it connected to a loss of resistance glass syringe for which I obtained depth information. So it was carefully placed and advanced under two different forms to make sure that in 3 dimensions, high, low, left, right, top, bottom, everything was correct.
But you testified no lateral image is required, right?
I am not in the custom of doing them prior to the incident with Miss Addison. It was not my customary practice. And I also testified that without being able to cite literature, that the standard of care in my community are that practitioners use single view. I testified to that.
Single AP view.
Yes, single AP view. That's
Now,
correct.
I want to talk to you about you agree that Miss Addison started showing symptoms at 10:34 in the morning, the decerebrate posturing?
Okay, that again, I'm not trying to be evasive. I am trying to be accurate. What I agreed to was I don't know the exact time. You keep using the word 10:34. My response is I completed the procedure. I turned around to clean the tray. And then the best response I can give you is that within 90 to 120 seconds of removal of the needle, I couldn't tell you if the time was 10:33 and 27 seconds or 10:34. That I don't know. That's why I'm trying to answer it precisely. What I'm saying to you is after the needle was removed without event or consequence, there was no signs that the procedure went awry in any way. Then I told you I turned to clean my tray, as is typical and customary of my fashion. I am a creature of rote. I do things same over and over and over. I guess it's similar to being, like a pilot. They have a checklist of things to do. I do things by rote. So I did turn to clean my tray. At that point, the patient was moved from the prone on the belly to the supine on the back position on the stretcher. They made it to the stretcher. And it was, as documented, between 90 and 120 seconds. And again, you keep using the term 10:34. I didn't check my watch. I don't know. My testimony is the procedure went without complication. The needle was removed. I turned to clean the tray. They flipped the patient onto their back. And then they said, Dr. Lee, the patient is having some duress. And of course, I turned to witness and see that posturing. In fact, I was the one who put it in my procedural note.
Miss Addison's decerebrate posturing occurred in the procedure room.
Agreed.
You were still in the procedure room.
Yes.
The 2 nurses were still in the procedure room.
Yes.
Arlena Addison was still in the procedure room.
Yes.
Arlena Addison left the procedure room at 10:34.
Okay.
Well, if you don't know or don't remember, tell me you don't know or don't remember.
I don't know the time. I'm sorry, I wasn't looking at my wristwatch, but that sounds right.
The medical record says that she left at 10:34. Any reason to believe we were given false or fraudulent medical records?
None whatsoever. I can't say enough about our staff and professionalism.
So if the medical records say that she was in the procedure room until 10:34, then the decerebrate posturing occurred before 10:34, right?
Yes, yes. It occurred in the procedural room. Yes. Now I can agree. If you give me, they physically moved her at 10:34. Yes, it did occur in the procedural room. I can agree with that. Sure.
And when the decerebrate posturing occurred, EMS was not called, right?
No,
EMS was, well, if it happened on or before 10:34, according to the medical record, EMS was not called by 10:40.
okay,
EMS was not called by, what, 10:45?
James, you may need to show him the medical record because he hasn't memorized times.
Okay. We're going to start with show you what's been marked as Exhibit 2 to your deposition.
This would be 3.
I'm sorry, 3?
3.
Thank you. Exhibit 3 to your deposition is the 911 call. You ever seen this document before?
I don't recall it as of today.
All right.
I may have, I don't recall it.
Okay. The address of the surgery center is 3672 Marathon Circle, Southwest,
That would be the location of our surgical center.
right?
Yes,
And June 9, 2022 was the date of the procedure, right?
agree.
And it reads here 10/44/38, June 9, 2022 is when this was created.
I see. I agree.
So that would be the earliest that EMS was called according to their timestamp, right?
Yes,
Reads here, OrthoAtlanta Surgery Center, that's where you were.
agree.
And you agree that from 10:34 to 10:44 is 10 minutes?
Yes, I agree with that.
All right. Patient having a bad reaction and convulsing. Do you see that?
Yes,
You would agree that Arlena Addison was having a bad reaction
yes.
and convulsing?
She was abnormal posturing. That word convulsing, like not like throwing up, but abnormal posturing is a better word. That's what I
Okay.
would.
Instead of convulsing, it would be better to read decerebrate posturing.
Fair enough. That's how I characterized it. The word convulsing probably means something different in my brain.
Right. And well, you characterized it that way also in your note, which we'll get to. You described what you saw, which is in medical parlance, decerebrate posturing, right?
Yes, yes.
Says CC text interfacility evaluation. That means because you're calling from a medical facility, right?
I don't know what CC text means. I'm sorry.
So the interfacility evaluation.
Yes. Yeah, we're calling from a medical facility, right?
Transfer 50-year-old female. You recall that Arlena Addison was 50 years old on June 9, 2022.
I don't know her birth date. I can't give that, but I agree that this descriptor is her. I do agree with that.
Okay. She's a female.
Yes, I agree.
She was, it reads conscious. You remember that she lost consciousness?
No, she never
Never
did.
lost consciousness? So
Nope. No, it's just stating that at the time that the request went out, that they're describing those are descriptors. So just like you pointed out, 50-year-old female, currently conscious breathing. It has nothing to do with, has she arisen to consciousness? It has nothing to do with that, in my opinion.
And so you're saying up here where it reads 10/44/38, 6/9/2022, she was conscious and breathing, right?
Yes.
The name of the person was Miranda. You see
Yes,
that?
I recall her working that day. I do recall that.
And who is Miranda Dudley? Is that right?
She's one of the nurses in our surgical center.
Right. You consider Miranda Dudley to be truthful?
I do.
Have you ever known her to say anything false or inaccurate
No,
or to lie?
no,
Previous incidences, do you see this number of previous incidents printed was limited to 2? There were additional previous incidents. You see that?
yes, I see that.
And those are incidences at 3672 Marathon Circle Southwest. That's the surgery center, right? Surgical.
Agreed.
Back to form, there's more businesses at that address than the surgery center.
Okay. So is it your testimony that neither of these occurred at the OrthoAtlanta Surgery Center?
I have no idea what that indicates.
All right.
I mean, can you help me with, I honestly want to know, are you saying that there were other calls made for care from our surgical center? I'm not sure what the point of.
Yeah, I am, and we'll get to those.
Oh, okay.
Yeah. Show you what's been previously marked as exhibit, it's 5, right, Madam Court Reporter?
4.
4. Okay.
(911), what's the location of your emergency? OrthoAtlanta Surgery Center of Austell. What's the address? 3672 Marathon Circle, Suite 120. I'll repeat that to make sure I have it correct. 3672 Marathon Circle, Suite 120. And what was the name of the business? OrthoAtlanta Surgery Center. What's your name? Miranda. And what's the number you're calling me from, Miranda? 678-945-8520. Tell me exactly what happened. We're a procedural center. We did a steroid injection. We need a patient transferred to Cobb. She's just having a bad reaction, convulsing. We can't get her to stop. So, okay, stay on the phone with me. I'm gonna have a few more questions for you. Are you with her right now? Yes. How old is she? Fighter. Sorry. She's 15. And is she awake? She is awake, yes. And is she breathing? She is breathing, yes. Was the patient seen by a nurse or doctor in the last 2 hours? Yes, there's an anesthesiologist at the bedside. And will the crew need to administer or monitor any medications? No. And will any special equipment be necessary? No. And will additional personnel be necessary? No. Okay, help is on the way as requested. Please have any advance directives ready for the paramedics, and if she gets worse in any way, call us back immediately, okay? Okay, thank you. You're welcome. Bye-bye.
Do you recall that ambulance call?
Not, making the ambulance call, yes, but not the voice. That's the first time I'm hearing that.
All right. Well,
I can recall that the call was made. Yes, yes.
all
yes
right.
to that.
And you were standing within earshot of Miranda Dudley when she made the call, right?
I'm going to go with yes. We were all in the same area of the PACU.
And Miranda described it as a bad reaction, convulsing, right?
Sure, I heard that, and it was documented as such. Mhm.
And she also told the EMS operator that we, quote, can't get her to stop. You see that?
Yes.
So this is 10:44 by their clock, their time. You may have had a slightly different one, but this had been, at least 10 minutes since she'd started the decerebrate posturing, right?
Okay, so if I might elaborate.
Well, first I'd like an answer, then you can elaborate all you want.
Okay, it has been 10 minutes. Agree, yes.
Okay. Now
So-
you're welcome to elaborate.
So
Yep.
from the time that the procedure was initially over, and people are using terms like decerebrate posturing, what I mean by that is flexed at the hands, straightening of the legs with the toes down pointed, and there was some shaking going on in the legs. And when she moved from the procedural suite, immediately there was care given at the anesthesiologist, and there was a critical care nurse. So the patient was moved in the position of the decerebrate posturing, but by the time Miranda made the call, neurologically, she was significantly starting to clear. This clenching behavior, rigidity, had reduced. What was of concern at that time, which may encompass the word convulsing, was the persistent straightening of the legs and the downgoing of the toes. But from top to bottom, this tightness had cleared. It was the lower extremities that were continuing to shake and go down. That's to my recollection. And if a different staff member, as you say, who I think is trustworthy, truthful, and honest, describes the stiff legs with downgoing toes as convulsing, I don't have a problem with that. It's just a different descriptor.
You ordered Orlena Addison moved from the procedure room to PACU, right?
I did.
After you observed the decerebrate posturing.
Agreed.
Before we played the 911 call, did you have any recollection of what was said on that call?
I told you it was the first time I heard it, so it's impossible for me to recollect it.
Okay. Well, I thought you testified you were in the same room, you were all in the same area when it was made. Is that right?
Yes.
When Miranda Dudley made that call, you didn't stop her either over the course of the call or after the call and say, oh, you said something wrong or inaccurate or incorrect or anything like that, right?
Oh, no. I would never question another team member and try to coerce them or tell them to say something different. No, I would never have done that.
Now, over the course of that 10 or so minutes from 10:34 when she left the procedure room until the call at 10:44, now I didn't hear Miranda Dudley say anything about decerebrate posturing. Did you?
No.
Okay. Nothing about loss of bladder control?
Not on the phone call. No, I didn't hear that on the phone call.
Nothing about unable to follow commands?
No, I didn't hear that on the phone call.
Nothing about decerebrate posturing being a sign of severe brain injury?
No, I didn't hear that on the phone call.
Nothing about bladder incontinence being a sign of a severe neurologic or brain injury?
I did not hear that on the phone call.
You knew that she was exhibiting those signs and symptoms.
She had transiently displayed those signs when she got flipped over onto the stretcher. And by the time she had gotten to the procedural bay, much of that has cleared up. So Miranda may not have given a history from 1044 till 1047 or whatever numbers you're giving me, but are you asking for my opinion? I'm not sure what am I allowed to say what I want? What are you? Okay, my explanation is that Miranda in the moment was giving as much of an accurate description of what was going on with the patient at the time of the phone call. That she wasn't trying to be evasive or say, hey, 10 minutes ago, the patient was this and that. She was in the moment making the call to ensure the patient got the best care and was probably just literally looking at the patient and saying, this is what I see. This is what's happening to my patient right now. Wasn't an attempt to say, oh, 5 minutes ago she was decerebrate. She had an episode of incontinence. I don't think that there's any purposeful, nefarious hiding of that. I just think she was in the moment and accurately describing what was going on at the time of the phone call.
Brain injury was part of your differential diagnosis for
Correct.
Arlena Addison on June 9, 2022, after her cervical epidural steroid injection.
I would prefer the term brain insult. Injury, to me, might connotate some permanency, but yes, as we talked about, something triggered this. There was a stimuli applied to the brain such that she behaved that way. Yes.
Well, although that was part of your differential diagnosis, you waited over 10 minutes to call 911.
She was clearing nicely.
So I'd like an answer to my question, then you
Oh,
can.
sorry. I'm sorry. I don't
Sorry.
mean to be that way. One more time and I'll answer your question, please.
Sure. Madam Court Reporter, do you mind reading that back, please, ma'am?
Question, so although that was part of your differential diagnosis, you waited over 10 minutes to call 911.
Agree, yes.
Do you agree that decerebrate posturing is a potential sign and symptom of a brain bleed?
Potentially, yes.
It's a potential sign and symptom of subarachnoid hemorrhage.
Potentially, yes.
It's a sign that she needs urgent medical care.
Maybe. The reason why the answer is maybe is, again, since I answered your question, I can now describe what's in my brain. She did display those behaviors. The word is transiently. Transiently, she displayed those behaviors. She was flipped onto her back. She was taken to the PACU. There was advanced staff available, including an anesthesiologist and a CCU-trained nurse. Devices and treatment was applied. In those 10 minutes, she was receiving intensive medical care. If the notes read correct and my recollection is correct, high oxygen was applied, vital signs were monitored, and over the ensuing 10 minutes, in those 10 minutes, that elapsed time, she significantly cleared. That needs to be known. She didn't display this for 10 minutes. It was transient. The loss of bladder control was immediate. This was transient. I recognized it as you say, a potential for a serious condition. And she was rapidly transferred over to the PACU. She was immediately taken care of by high-level caregivers, including anesthesiologists, CCU. Monitoring was had, oxygen was applied, and appropriate fluids were given. That's what was happening during those 10 minutes. And in those 10 minutes, she cleared. And at the time of the phone call, Miranda is saying what she still sees. Much of this had cleared. She's seeing that the legs are still straight and the toes are down going. That's the best that I can, under truthful, what I've been sworn to tell the truth the best I know it. That's what I'm saying. That's what I'm saying.
You never spoke with the receiving hospital doctor about Arlena Addison?
I don't believe I did. No, I don't have recollection of such a thing. I
Don't believe
did
you
out of
did.
care. Out of care and concern. After the transfer, I did call the receiving hospital. Your specific question is, I speak with the doctor. I don't believe that I did. I did ask for an update in how she's doing. Someone from the receiving hospital at Cobb in the ER did speak with me and say that she is improved. That I did do. But you had asked a specific question. Did I speak with a receiving doctor to the best of my ability? I don't believe I did.
And had you done so, you would have been required to include that in your notes, right?
Surely, surely.
You agree the standard of care requires confirming contrast flow before injection?
I do.
You agree the standard of care requires stopping the procedure if contrast is not visible?
I agree.
You did not stop the procedure?
I did see contrast.
Right, you did not stop the
I
procedure?
did not stop the procedure.
You injected drugs, saline, air, and dye?
Yes, that was all part of the procedure. Agree.
You agree a misplaced injection can cause a catastrophic injury?
It's within the realm of possibility, sure.
Miss Addison suffered a catastrophic injury?
I wouldn't know. I've not spoken with her. I don't know her current status, so I cannot comment on that.
And the injury occurred immediately after your injection. You said 90 to 120 seconds.
Before onset of symptoms, I did say that.
And it's your testimony that you can tell by the 1 AP view that the needle was properly placed?
In my experience and opinion, again, in the 26 plus years that perhaps I was doing 3 a week times 26 years, we can do the math. I don't know how many I've done. I am experienced in doing this. It is not my normal pattern to get to view on all occasion. Again, I have already described to you my technique in which I use the AP projection to accurately place the needle direction, and I use the glass syringe to accurately gauge the depth. I've described that to you. Was that to your satisfaction?
Is there something you're looking at to your left?
No, I'm trying to figure out why we're quiet for so long. That's all I'm doing, trying to stare at the screen.
I'm just following my cross-examination outline. That's it.
Okay, I'm sorry if I'm not like staring at the screen, but that awkward silence probably had me shifting my head, but I'm not looking at anything. I'm focused on
Right.
you.
So you didn't review Miss Addison's hospital records?
Not formally, no, I have not.
Well, what about informally?
Well, I guess informally means I asked about her. I attempted to call her using office equipment. So I called the hospital. I asked for an update, as is common for my practice. I do care. I want
It's
to know.
required by the policies and procedures, right?
Sir,
It's required by the policies and procedures.
absolutely. But more importantly, it's because I care. Yeah, of course I checked up on her.
Show you what's been previously marked. Is it Exhibit 5, Madam Court Reporter?
That's correct.
Wow. Got one right. Exhibit 5 was provided to us in this case. This
Hey,
is
James,
a-
you've got the CV up there right now, but you did have the photo up, but then it went away and the CV's up now.
Is that it?
I see a photo.
You see the fluoroscopy image?
I do.
Okay, I'll show you what's been previously marked as Exhibit 5 to your deposition. This is a fluoroscopy image for Arlena Addison.
I see the name.
Well, this is a fluoroscopy image for Arlena Addison. Is that your?
Yes, I'm agreeing with you because I see the name on the photo. I was trying to agree with you. Yes,
It reads Lee, that's you. That's the physician, right?
it is.
And C6, 7 ESI, that's the procedure, right?
The level of the procedure.
Cervical 6, 7 epidural steroid injection, right?
Right.
Over on the upper right, OrthoAtlanta Surgery Center, that's where you were, right?
I see that and I agree.
And immediately beneath that is a time, 6/9/2022. That's June 9, 2022, right?
That's a date to me. That's a date, but I see
The
the
date.
date. Yes,
The date is June 9, 2022.
I see that. Yes,
That's the date of the procedure.
yes. You asked about time. To me, that's a date. I'm just trying to answer your questions correctly. That's a date.
Thank you. The date is June 9, 2022.
Right. Agree.
And the time, do you see this? I'm making it larger. You see where it reads 9:59:26 a.m.? You see that?
I do.
And 9:59:26 a.m. comes before 10:24, right?
Agree. Agree.
And Arlena Addison on June 9, 2022 was in the procedure room where the CRM is from 10:24 to 10:34, right?
Agree. Agree.
She was not in there at 9:59 a.m.
I agree with that statement as well.
And do you see this on partially covering up the time on this fluoroscopy image for Arlena Addison on June 9, 2022? You see where it reads 11/41/26, 1970-0202?
I see that.
Yeah. And we've got some other fluoroscopy images for you. They don't have this 11/41/26/1970 on them. You agree with that?
I don't know. I haven't seen the other fluoroscopy images, sir.
All right. Did you have a role in placing the 11/41/26/1970 on top of the time on this fluoroscopic image?
No, that's not part of my role.
Okay. You agree that Arlena Addison was also not in the procedure room at 11/41/26?
Agree.
Because that would come after 10/24 to 10/34, right?
Yes,
You agree too that this timestamp, the 9:59:25 or 26 that morning, 9:59 that morning is supplied by the machine, right?
yes, the machine, well, I don't know the inner workings of the machine, but I can say with confidence that the machine has an internal clock. I can say that with confidence,
Right.
okay?
And the internal clock, that's one of the things that would be checked when you do a timeout before you start a procedure, right?
No, it's not necessarily the case. The reason being is the fluoroscopy machine is notoriously fickle, and we do make every effort to keep them all up and running in pristine order and good maintenance, etc. But from time to time, a machine will go out. Again, I'm no computer expert, but I would imagine there are computer chips inside that fluoroscopy machine, much like your laptop computer. If it ain't turning on, you're going to have to unplug it and reboot it. We've had to do that before.
Right. And before you begin a procedure, just like Arlena Addison's on June 22nd, 2022, on June 9th, 2022, you would call a timeout, right?
We did.
And you would have a timeout to ensure that it was the right patient,
Agree.
the right procedure,
Agree.
that you have the right equipment,
Yes.
and the equipment is functioning properly.
Agree.
And that's all required by the policies and procedures, right?
Agree. Can I make a comment now? Because I agreed.
You can,
Okay. So my comment is all the information to the top left, as far to the best of my knowledge and ability, the information to the top left is put in by a team member, exactly as you described, to make sure this is the information. The top left information is the information we use to do our timeout. Exactly what you said. Name, identify their date of birth, who the operator is, and what the procedure is being performed. The information to the top right is pre-populated. It'll always say OrthoAtlanta Surgery Center. The information below that is machine generated. So no, we in our policies and procedures focus in on the information to the top left. The information to the top right, to the best of my knowledge, is again computer generated from the machine itself.
and by the top right, you're talking about OrthoAtlanta Surgery Center, the date, June 9, 2022, and the time of 9:59 that
Yes,
morning.
yes, that's not inputted by a staff member. That is not, to the best of my knowledge. I'm not a machine repairman, so if I'm speaking out of turn, you let me know. I'll just be quiet. But that's my understanding.
You agree the OrthoAtlanta Surgery Center, that's correct.
Yes,
Right.
it's pre-populated that way. Yes, it's always there. That's static.
But pre-populated, you mean generated by the machine?
Yes, yes, I do.
Right. And that, while pre-populated, is correct.
Uh-huh.
Yes, I know we all do that. It's hard for the court reporter to take that down. Is that a yes?
Yes, yes. Sorry.
And
Yes.
the date, it's all right. The date immediately beneath that, 6/9/22, also pre-populated by the machine, right?
To the best of my ability, that is not entered by a team member. It is not.
And it's also correct. right?
Okay,
And now the 9:59 and 25 or 26 seconds that morning also pre-populated by the machine, right?
so that machine's internal time clock may have been off, but the date could have been correct. Yes,
Okay. My question was whether that's pre-populated. It is, just like the OrthoAtlanta Surgery Center, just like the date, pre-populated, right?
I think it's machine driven, yes.
And both the location and the date are correct.
Uh-huh.
Yes,
Yeah, oh, sorry. Yes, I'll
all right.
try. I'm gonna do better. Yes, yes.
That's all right. And the time you're suggesting is the only thing on this document. Exhibit 5, is this exhibit 5? Exhibit 5, your deposition, that's inaccurate, right?
That's all that I can see.
All right. And you don't have any idea how the 11/41/26/1970/02/02 made its way onto this image?
I have no idea,
All right.
but you were asking me about timeouts and some procedures and protocols. So my response would be, that is how the staff's medical records are generated. Time in, time out, time during procedure. Those are, again, all human inputs. I would trust the human inputs. So if the information to the top left of the screen collaborates the written record that you have access to, I would go with that information, because we do the timeouts. They are appropriately documented in real time. And if all that information collaborates, then that's the information I would agree with.
And do you see this line in the center, the dark black line?
I do.
And that's the needle, is that right?
It is.
And it's your testimony that that needle is accompanied by dye, is that right?
It is. It's the black portion above the needle. There's a small quantity of dye instilled to change the color from, if you notice that the way X-ray works is negative space appears white, denser space appears darker. So the needle is darkest, makes sense. It's metal, so it appears the darkest. The space above and below the bone is bare white, makes sense. That there's not a structure there. That's how you access the cervical epidural space. And then the picture captures, if you look above the needle, you will see a circle. Do you see the round circle?
I'm not sure. I do not. Maybe,
Okay.
can you see this cursor?
Yes, that's the round circle I'm talking about. That is it. So that's what we call the spinous process. You can feel it on your own body. If you press the back of your neck, you'll feel a little numb. That is the spinous process there. And so that
I'm going to
whole,
circle that. Is
Yeah,
that where the
that's
red
a
circle
spinous.
is? That's the circle you're talking about.
and its name is spinous process.
All right.
And then the rest of the rectangular bone, can you circle the rectangular bone above the needle, the entire rectangle? No, that's the bottom. That's the bottom plate. It also has two side plates and a top plate. It's a rectangle. It's a bone.
You're talking about the entire, okay.
Vertebral body, yes.
Sure, I can do that. Mm.
Okay, but lower than that. You've covered too much of the top. You would drop the top down to just in case the bone, only the bone. too high. No, I'm sorry.
It's all right. We'll get it. This is the disc, right? You see the
Agreed,
cursor?
agreed, that the white
This
space
is a
is the
disc.
disc.
Hold on. This is a disc too, right?
Agree,
And the bone is between these discs, right?
agree with that too.
I'm going to do a square, and I'm going to start.
Little lower, little lower.
What?
A little lower, if you would start your square a little lower,
Okay.
lower. That's still the disc where it gets dark.
That's where the disc and the bone. That's disc. That's bone. See that?
Agreed. So let's just go to the top of the bone. That's what I'm asking. The vertebral body, the bone. I'm asking to outline just the bone, not the disc. Yes, yes. That's the vertebral body, the bone. I agree. That's
Well, it
the
needs to
bone.
go. It's higher than that, I think.
So what I see, yeah, slightly higher. So it's an alternating band of white, gray, and white. If you would capture the gray, that would be the vertebral body. Yes, that's the vertebral body.
All right.
Okay.
And the needle is the black line.
Yes, it's the densest. It appears the darkest on X-ray. It is the needle.
I'll try to circle that. Whoop.
Vertebral body.
Yep.
Okay.
We got to go back to the circle. And this,
So if I may,
I'm going to go ahead and I'm going to
okay, that's fine.
see where this is needle. Is that right? I've drawn
Yeah,
that.
if you take it off, I think I could better explain it to you. It's up
Sure.
to you. All right.
All right.
Okay, so what you're seeing is a needle and it's angled and it's going from the lower part of the screen to the higher part of the screen. The lower part of the screen, you're going to see that the needle has like a bulbous portion. That bulbous portion is the hub of the needle. The hub is what connects to the syringe. And then as you move
And the
from
ball, hold on, I want to circle the
hub,
call it the hub, right?
I did the hub. That's the hub of the needle.
And I circled that and I'll write. Is that right?
Yes, if we go from the hub and we go from left to right, going upward, that
Right.
whole straight line is the shaft of the needle. That is what we
Right.
call the shaft of needle. And I
Right.
don't know if you appreciate it, but
I'm just going to do a line parallel to the needle. That's the needle, right?
yeah, the shaft of the needle, shaft.
So we don't need that.
Okay. All right. So then if you follow the shaft all the way out, I don't know if you appreciate it, but there is like a diagonal there at the very tip. Do you see the tip is not flat, but it's diagonal? The very, very tip of that needle.
I see a shadow that appears that way. The needle does not appear to me that way, but
Okay. At the very tip of the needle is indeed angled. That's how you identify it's the tip of the needle. So then to the right of your circle in that rectangle, that dark gray that you see is the dye flow from the tip of the needle. That is the dye that is used to confirm. Because again, get that area there. Because,
all right, I'll mark that and I'm just going to draw a line.
okay,
I'm going to write dye.
yep, And
Okay.
the reason I say that is because in your diagram, you have made a rectangle and captured the outline of the vertebral body. And it's important to understand where the tail and the tip of the needle are, the tail being the hub. That's what connects to the syringe. The rest of the needle, if you can imagine, this is a 2D picture, but in a 3D world, that shaft is going through the skin, through the muscle, and the tip is being placed in the epidural space. That's what's happening in the real world. Small amount of dye is being injected, and the dark area is the pickup of the dye, because that's what dye is. Dye is a contrast. It contrasts to what's normal for the body. It's different than what's in the body. So if the entire vertebral body that you put into the rectangle, the left side appears to be more gray and the right side appears to be more dark, it's because dye was instilled there. And you were asking something about what structures can you see. I wasn't being evasive. I just tried to the best of my description to tell you it's a blob. That's what I see. I see a dark gray blob, and now you've identified the blob.
It's your testimony that what we've indicated, the gray to the right of the small circle inside the rectangle
Yes.
that reads dye, that's
Yes.
the.
Yes, my interpretation of that image from that day is that is dye, and I was satisfied it wasn't the correct interpretation. That is my testimony.
All right, I'm got 17, 18. It's about 20 afternoon. I'm going to break for lunch. You want to start back at 20 after 1:30? What's
Let's take no more than 30 minutes for lunch, James.
I won't be able to do that, but I mean, we can start back at 1:17.
How about 1 o'clock?
No, 1:17.
All right.
Thank you.
We're going off the record at 12:17 p.m. We're back on the record at 1:18 p.m.
Dr. Lee, I'm showing you what's been marked as Exhibit 5, and we've got the spinal process, the vertebra, the dye, and the hub. The dye, we've got an arrow to the dark space that you characterize as the dye. What I'd like for you to do is I'm going to put a dot on the upper left, upper right, lower left, lower right, so that we're accurate on the dye. And then I'll connect those dots. How's that?
Okay,
Can you see where the pin is?
I do.
Is that the upper left?
Yes, anywhere the dark spots are.
Okay. And then see where the pin is? That's the upper right. Is that right?
As long as it's not being obliterated by the top line, you know how there's a top line there? I don't know if there is some of the dark dye underneath your top orange line. That I cannot tell.
Well, I can remove that line.
Okay, let's do that.
Okay.
That way I can see 4 clear dots.
Okay.
Well, go ahead
I'll
and make your
remove-
4 dots then.
I'll remove this dot too.
Nice, nice.
All right. So where the die is, if you could point me to the upper left corner of the die.
Okay, that's about right.
All right, upper right corner.
Yes, no, yes, corner, yes.
Is that right?
Yes, yes, corner.
Lower right corner.
Inside more. About there.
Okay. Lower left corner.
Hard to say. To the left slightly, sir. There's good.
Okay. And so if I connect these dots, that's where the die is. I'm going to go left to right on the top, left to right on the bottom, and then well, around this, right?
Okay.
Is that right?
If we remove the circle, maybe we'll see dye below the circle. I'm not sure.
Okay. Can we remove the circle?
Yes, please. It's a fair representation.
That's where the dye is?
Yes,
Okay. And the other, we've circled the hub of the needle, right?
correct, agree.
Okay. Then the long dark line is the needle,
Shaft, agree.
the shaft.
Uh-huh.
Oh, you call it the shaft of the needle?
I do.
Okay.
That's what I call it.
Save that. I'm going to show you what's been previously marked as number 6. Is that right, Miss Bonnie?
That's correct.
Thank you. Number 6. This appears to be, this is a fluoroscopy image, again for Arlena Addison. You see that?
I
And
do.
this is DOS, that's date of service, right?
Correct.
9/15/19. And here you saved 2 images, is that right?
Appear so.
And if we enlarge the image on the left, can you just show me where the dye is in that image?
I can't because it's so blown up. The pixels are distorted.
How about now?
Where, if you can show me hub and tip.
Well, I can't really, I'm just showing you the films that we were
Okay.
providing.
Well, I would simply say this. The lower part is the hub, the upper part is the tip. If that makes sense.
Yeah, do you see the needle here?
I do. I'm trying to orient the needle now. So if you follow it north, then that would be tip.
Okay.
Highest portion is tip.
Is that where the arrow is pointed now? Is that the tip?
Yes, tip of needle, yes. And
Okay.
then distal to that, there is just a small gray cloud formation just at the tip. There is a gray cloud formation.
So I'm going to make the dot. That's the
Yep.
tip.
That's right, agreed.
Okay.
It's not linear like that. It's more of a blob. Oh, tip, you're spelling the word.
All right. And the contrast is where?
From the tip in
Uh-huh.
a circular formation to the right.
Right here.
A little more than that to the right.
Yeah. You tell me how far right to go?
That far.
Okay. And how far left to go?
I would go slightly higher too.
What?
I would go slightly higher than that.
Higher on the right?
Yes,
Okay. Right here?
higher into the inside, sir. Yes,
Right there?
yes, yes.
That's the top right corner of the contrast dye?
It's not a corner, it's more of a blob. It's rounded, but that would be the height. Yes, the height.
Okay, that's the top, right?
Agreed.
And to the left?
About to the right a little more. There.
Okay. And to the right?
Go more left. Right there.
And that's a circle?
To the tip. All four, all like a diamond, I guess, but I wouldn't, right, I wouldn't make it a linear line. That's what I'm saying. Yes.
Is that right?
Yes, yes, yes.
Die. This is from the same day. You see the needle here as well. This is the same exhibit number 6. This is a photograph on the right. Do you see the point of the
I'm sorry, can you help me again? You said from the same day. Are you saying it's the same picture, or are you saying they're two separate pictures from the same sitting? I'm not following you there.
I don't know. That's what we were provided. See where it reads chart name Arlena Addison up
I
here?
do, I do.
See where it reads date of service 11 9/5/2019. Do you see that?
I do. I see that as well.
And you see the doctor here, that's you, right?
Agree.
Dr. Yong Lee, date of service 9/15/19. Arlena Addison is the patient.
Uh-huh.
She was 47 then, right?
Oh, I'm not so great at math, but I'm going to agree with you on that.
Got it. So we identified the tip and the die in the photograph on the left. And now the photograph on the right. Is that the same?
That's two, yes, I see that again. From starting at the tip, I do see a circular structure that represents die. Starting at the tip,
Okay. And is that the tip?
yes, agree.
And the die is where?
From there is fine.
Okay, and to the left,
That's fine.
to the right,
That's fine.
and a diamond shape back to the tip or a circular
Yeah,
die?
but yeah, it's more of a circular shape. I wouldn't make it a diamond. That's not how fluid flows. Right, correct. Fluid doesn't flow like a perfect diamond.
I'll show you what's been previously marked as Exhibit 7. This is another image for Arlena Addison. Is that right?
Yes,
And you're the physician, just 2 E's and Lee.
you are correct, sir.
All right. And this was 12/15/16. And you don't see that overlay over this date and time, do you?
No, I don't.
Okay. And can you see in this photograph the tip of the needle and the die?
Yes, the tip of the needle is right there.
Okay. Right here?
Yes, correct.
Okay. And the die is where?
It fills the entire right side. This time it goes higher. The die
Okay.
on this, we're sitting higher. And then to the left.
Right. Is this
The height is correct. Could you go left, please?
Sure.
Continue. That's the height of the die.
Right here?
No, to the left, right there. That's, for. No, to the right, sorry.
All right. Here,
To the left a little, drop down barely. Yes, yes,
okay. And now on the left,
it goes further than that to about, to the right, slightly to the right, slightly to the right, slightly to the right. That's it.
okay. And over here on the right side,
It basically conforms to this, the shadowing of the bone, the very dark area. It looks like two
this,
peaks to me. No, if you come left, it goes from gray to dark, right there at the dark boundary. That's it.
Okay. So um, here,
Uh-huh,
here,
uh-huh,
so the needle tip here
uh-huh, uh-huh.
and here.
That last line you drew is incorrect. It actually,
Okay, let's fix it. Yep,
okay, yeah, it bulges out to the dot. See where the T and tip is?
yep.
Yeah, it goes out that far. Yep, and then pat back around. Yep, I like that.
I'll show you what's been previously marked as Exhibit 8. Now, this is another film for Arlena Addison, right?
It is labeled as such, yes.
And this is, you're the surgeon again, Lee, with 2 E's?
This time two E's, yes.
Yes, sir. And if you look over on the left, again, OrthoAtlanta and the date and the time, neither of these dates or times are covered by that overlay, right? The 1972 overlay.
I don't see it there.
Okay. Now, can you see the tip of the needle in this film?
I do.
Let me make sure. Is my cursor over it?
Yes.
All right. And the contrast in this film is where?
Actually, a little bit below the tip this time, the contrast flowed below to that higher slightly, just to the light gray. That is what I would consider contrast.
Okay,
Right
right here.
Yes, yes, the light gray,
Okay. And on the top?
up to there,
Okay. And on the left?
slightly to the right, somewhere there.
And on the right?
Uh, you have to go left more to the dark area right there.
Okay. Let me try again on this. More or less straight lines between these points or curved?
Slight curve, because again, fluid doesn't flow in a straight line.
Uh, Is that right?
Satisfactory.
And James, could you upload this to the chat?
Oh, I apologize if I didn't. Yeah, let me do that. There you go. And that is number 8. And you made notes for each of these, right?
No, I've not made notes. Should I be making notes?
No, you made, I apologize. I'll do a better job with my question. When you perform these procedures for Arlena Addison, these epidural steroid injections, both cervical and lumbar, you made an operative note, right?
Yes,
Just like you did for June 9, 2022.
yes,
Okay. And each time you made those notes, you would, record them? You,
dictate them, transcribe them, yes.
yeah, okay. I'm going to show you what's been previously marked as the exhibit 9 to your deposition. These are the medical records for June 9, 2022. You reviewed these, right?
I'm pulling them up now.
Okay.
Yes, I've reviewed this record.
And this record is for Arlena Addison,
I see that, correct,
dated June 9, 2022.
correct.
And the procedure is a cervical 6-7, that's a C6-7 midline ESI. Is that right?
Yes,
The physician, that's you, Yong Lee.
that's correct.
And we scroll on down, these are consents, the first several pages, right?
They appear to be.
Okay. Well, the consent down to, looks like on page 10, pre-admission questionnaire. And then we get down to on page 11, Mark, you see where it reads page 11 of 39?
I do.
And this is a pre-operative department. That's before the procedure, right?
Yes,
That reads pre-operative 9:55, out 10:24. When she's out of the pre-op at 10:24, that's when she's in the procedure room, 10:24, right?
or within a minute, yes.
Well, we'll go on down.
Okay,
See pre-operative assessment, preoperative assessment, blood pressure is 102 over 67, heart rate's 88, respiratory rate 16, oxygen saturation 98. You see that?
I do.
98.1 temperature. All within normal limits, right?
Agree.
Then we go through the preoperative work list. Placed a wristband, confirm the identity of the patient. H&P completed. Do you see that?
I do.
If she had a history of seizure, well, the H stands for history, right?
Agree.
And the P stands for physical, right?
Agree.
If a patient had a history of seizures, as you suggested some do, that would be included here, right?
Agree.
And since there's zero notation of a history of seizures, that indicates that according to the history and physical performed on June 9, 2022, there was no history of seizures, right?
Agree.
NPO, I mean, she's had nothing to eat or drink since 10 o'clock the night before. Is that right?
Makes sense. That's what I see.
Then we go on down, preoperative updated patient history. Down here, now we're on page 14 of 33. Pre-operative Dr. Lee, cervical ESI pain management. That's why you're doing this epidural steroid injection, right? Pain management.
That's right.
And it's administered date and time. This is a medication administration record, or MAR, right?
Okay, yes, I agree.
And it is dose and route, and it's 1 IV. And this is midazolam, 1 milligram per milliliter injection solution, right?
I agree.
And that's another name for Versed, right?
I agree.
And it reads that this was administered at 10:15 on June 9, 2022, before her surgical procedure, right?
Agreed. It's a loading dose. I agree.
Then operative department, you see this? Operative department, operative in, operative out.
Yes,
You see where here it reads room, procedure room?
I do.
What this indicates, according to the records, that she was in the procedure room at 10:24 and out of the procedure room at 10:34, right?
Yes,
That indicates that her brain insult, the term you used, and her decerebrate posturing occurred between 10:24 and 10:34 that
I
morning.
would agree with that. I would agree with that.
Okay. Incision procedure times, looks like you did the injection at 10:29 and ended the injection at 10:31. Is that right?
I see the numbers. Yes, I would agree.
So her decerebrate posturing didn't start until after the injection, right?
Agree.
Yeah, and you agree where it reads incision for your procedure, it's actually injection, right? You incise the skin, but with a needle.
Agree with that
Yeah.
statement.
So it happened, her decerebrate posturing actually occurred sometime after 10:29, after 10:31, and before 10:34, right?
Yes,
Because it happened 90 to 120 seconds after the end of the procedure, after the injection, right?
to the best of my recollection, yes.
And Emily Doyle, she was your nurse that day, right?
Agree.
That was 6/9/2022 at 10:29, still in the procedure room, right?
Yes.
Any reason to believe Emily Doyle would say anything untruthful or misrepresent anything in Miss Addison's medical record?
No, I have no such concern.
Okay. Timeout verbalized. In other words, what that means is that everybody agreed on the end time, 10:34, right?
Time out. I don't know if that means when she left the room or the procedure was completed. Those are two separate events.
Okay. But it was recorded by her at 10:29. Is that right?
I see that.
Okay. And this is everybody who was in the procedure room. See where it reads staff, Emily Doyle.
Yes,
She is a registered nurse and she acted as your nurse.
agree.
Miranda Dudley, she's a registered nurse. She acted as the C-arm operator.
Agree.
Yong Lee, that's you. You acted as the surgeon.
Agree.
And you all agreed, according to these notes, the time in and the time out of the procedure room, right?
Agree, I see that.
Emily Doyle, 1024 to 1034. Right?
Yes,
Miranda Dudley, 1024 to 1034. Right?
right,
And you yourself, time in, time out, according to you, the surgeon, Yong Lee, right?
right.
And so at 1034, the decerebrate posturing had already occurred.
It had, because it occurred. Again, the word time out, I'm not sure if time out means time out of the procedure, not time out of the procedural room. That I'm not sure of. When, even on these printed records, that phrase time out, as in like the needle has been removed and the procedure has been completed, that could be time out. Time in is when the needle is placed in, time in, and then time out. It may not necessarily mean the time out of the room.
No, the time out of the room is 1034, right?
If that's what all the documents agree to, I will say yes. I will say
Well,
yes.
if you don't know, you just tell me you don't know.
I wasn't looking at my wristwatch when she left the room, so,
Sir, my question had nothing to do with a wristwatch or any
Okay.
other kind of
all
time.
right,
My question is, according to these medical records, I think we've already discussed the importance of medical records. It's a medical legal document and it's important for your patient safety.
Yes.
We reviewed them before this deposition and you didn't see anything that was remotely akin to inaccurate, right?
agree.
All right. So it says both here on page 14 of 33 and 15 of 33. Operative, that's the room, procedure room. They make it real clear here, right? They tell you exactly
Yes.
what room she's in and
Yes.
when she's in it. She's in it from 1024 to 1034, right?
I see that.
You don't do epidural steroid injections in any room at OrthoAtlanta Surgical Center other than the procedure room, right?
Agree.
There's a reason for that, right?
Yes.
Your patient safety.
Agree.
That's the room that's set up for these procedures, right?
Agree.
There is no other room set up for those procedures there.
Agree.
Okay. So does that help refresh your recollection about the time in and time out, 1024, 1034?
Yes.
And it makes sense why on page 15 of 33, why on the day of the procedure, the staff, Miss Doyle, Miss Dudley, and yourself all agreed that the end time was 1024 and the out time was 1034, right?
Agree.
And she's transferred to recovery. That's PACU, right?
Yes.
That's at 1034. Right?
Right.
And that she's transferred on a stretcher. You see that?
I do.
And the operative assessments, you see where it reads assessment date time 6/9/2022, 1034. So that's after the procedure.
I see that.
Yes, sir. And we've got a number of vital signs taken by the nurse, Emily Doyle. See that?
I do.
Case details. We're now on page 17 of 33. Cervical 6-7 midline ESI, that's a procedure, right?
Yes.
Pre-op diagnosis, radiculopathy, cervical region, right?
Yes.
Post-op diagnosis, radiculopathy, cervical region. Is that right?
Yes,
So it's the same before and after the procedure, according to, this is according to you, right?
yes.
And I don't see anything here in these case details about decerebrate posturing, about the explanation of decerebrate posturing, about loss of bladder control. I just see the same pre-op and post-op diagnosis. You see that?
I do.
You agree that if you've got a post-op diagnosis that's different from the pre-op diagnosis, an accurate medical record ought to include that, right?
That was placed in my procedural note, the accurate medical record, the detailed accurate medical record that you're asking about was placed into my operative note.
So your testimony is it doesn't belong here in case details. Is that right?
No, I'm not saying that. I'm saying that above that, it says operative work list, and this is something that is pre-generated.
Pre-generated by who?
I think the computer, that's why that you see the pre and the post. It's templated. I don't know if it's generated is the right word. It's templated. This is a template as far as I can assess it.
You
It's
see
like
here,
a checklist. Yeah, there's a checklist you can check. And did you use X-ray? Yes. And you don't manually put in like post-operative diagnosis. The diagnosis, I think, it feeds into this form. It's a form that gets filled out, and there are fields, and the fields get plugged in from other data. And there are places in that form where there's probably a checklist, and hey, on this case, did you use X-ray? Yes, and then it would fill in yes.
see where it reads X-ray, yes. The equipment is a C-arm.
I do. I see that.
That was what was used, right?
Yes.
And that was at the procedure site, which is a cervical spine.
Yes.
And the type of equipment, this is on page 18 of 33. Reads C-arm series 9600,
It's the model number of that particular
Right.
piece of equipment.
but it was actually the 9800, right? If you know.
I don't know.
Okay. Now, the site marking you did before the procedure and not in the procedure room, right?
Yes.
Now, this is page 19 of 33 still. Is this exhibit 9? Operative Dr. Lee, cervical ESI pain management. This is the balance of the MAR medication administration record, right?
Yes.
And here it reads midazolam. Again, this is Versed, right?
Yes.
And Versed is a benzodiazepine.
Yes.
And it reads the date and time that it was administered. That's 6/9/2022 at 10:28 that morning.
Yes.
This is the dose and route. This is another 2 milligrams by
Yes.
IV, right?
I see that. Yes.
Administered by, charted by, looks like it was administered by you and charted by Emily Doyle.
Yes.
And this is the second dose of Versed. The first dose was before she went into the procedure room, right?
Correct. Correct.
And that was 1 milligram. So it's a total of 3 milligrams at this point. Is that right?
Agreed.
Then she was also administered another 50 micrograms of fentanyl.
Yeah. Yes. Yes is a better word.
That was at same date at 10:28 in the morning, which also indicates this was in the procedure room, right?
Yes. If your time stamping is correct from time into the room at 10:24, time out of the room at 10:34, then this timestamp of 10:28 means 4 minutes into the procedure, she would have had this dosing, and that would be appropriate because at 4 minutes into the procedure, a needle would have been placed through the skin into the muscle. If she had some complaints of discomfort, it would be appropriate to administer these type of medications before completing the procedure. So the 10:24, the 10:34, this being at 10:28, at 4 minutes into the procedure, to the best of my recollection or my typical practice policy would be to have cleanse the skin sterile, numb the skin with local anesthetic, and pass the needle through the numbed skin. By use of local anesthetic to the skin and underneath the skin, you can dull the sensation of pain of passage of a needle. But for those 4 minutes from 10:24 to 10:28, the needle tip is being advanced slowly and carefully and dependent on the patient response. Oh, I feel that, or some low-grade murmur or kind of thing. I would ask, and is the patient comfortable? Can you check the vital signs? If they're not in a comfortable position to maximize safe placement so the patient doesn't move, it would be decided to give Versed and fentanyl 4 minutes into the procedure in keeping the patient comfortable and not moving.
Local anesthetic is lidocaine, right?
Yes.
And you administer the lidocaine, as you just testified, before you insert the needle, right?
Yes, I do.
And you administered the lidocaine at 10:29.
That
So
would
you'd
be an
already
error.
administered both the Versed and the fentanyl before you administered the lidocaine, right?
I would think that would be a charting error.
Okay. You think it's an error because it's got 10:29 for the lidocaine and 10:28 for the benzodiazepine and the narcotic?
If it's not a charting error, the patient may have come in a high anxiety state. I have been told on occasion, Dr. Lee, the patient is particularly anxious or nervous. Might we give medication before you anesthetize the skin? That would not be it would be out of my typical sequence, but not out of my practice. I would have done that before. That is possible. That this is, the timestamping could indeed be correct.
For accurate medical records, though, had that happened, you would have noted that in the medical record. Right?
So I would say that this is correct. The timestamping and sequence of events as listed here is correct. She was, again, pre-medicated prior to application of lidocaine on the skin, because application of lidocaine to the skin in and of itself is a painful process.
Got it. So then we've got the dexamethasone, 10 milligrams injection solution, 20 milligrams IV site. You see that? Not administered.
Okay, I see that.
So you did not administer the dexamethasone according to this record?
I'm not sure what that record is saying, because IV site, I would never put the dexamethasone through the IV. It would go
Right.
through the epidural space. So I don't know what that IV site means, but no, I've never placed dexamethasone through the IV. She did have an IV in place.
And here it looks like Omnipaque, 180 milligrams, iodine, intrathecal solution, 3 milliliters, local surgical site. You see that?
So what that means is 3 mLs was drawn up into a syringe, not all of which needs to be used. In fact, in a 3 ml syringe that is full of dye, I often use the least amount of dye necessary to convince myself of safe needle placement.
Okay. And according to the medical record where it reads dose, the dose was 3 milliliters, right?
According to the medical record, but oftentimes I will use less than what's in the syringe. It may be a half cc to 1 cc.
Well, an accurate medical record should reflect the actual dose where it reads dose, right?
I don't disagree.
Sir?
I
Sorry.
don't disagree. I do not disagree. I do not.
This is just another issue with the medical record, do you think?
I wouldn't know.
Okay. Wherever it reads not administered, like the normal saline flush. It's your understanding that those drugs were not administered?
I understand the word not administered. I understand that word.
Mm-hmm. Well, it's 2 words, a phrase, but okay. My question's a little different.
Okay.
Do you agree where the medical record reads not administered, that those drugs were not given?
But into which site is my concern. I place a syringe and the contents of the syringe contain the steroid, the normal saline, and the separate syringe contains the omnipate dye.
And that's what you did to
Yes.
Addison on June 9th.
Yes, yes.
So if the record does not agree with that, your testimony is that's an issue with the record, right?
I'm not sure what the record is saying here. It says normal saline flush 3 ml through the IV. I don't understand what she has an IV in place, and these type of medicines aren't being administered through the IV. I would agree with that.
Right. Recovery department. This is we're page 21 of 33. Do you see that?
I do.
Operative nursing notes. You read the procedural medications versus in fentanyl administered by Emily Doyle, RN.
I see that.
Then the next note is by Miranda Dudley. Procedure complete and needle out at 10:31. So there's 10:31 again. The decerebrate posturing occurred 90 to 120 seconds after that, according to the medical record, right?
Yeah, so 31 plus 2 is 33, so it could be a minute off. Sure, yeah.
Yes, sir. And Band-Aid was applied to injection site. Patient started to complain of her legs shaking. Patient then became tachypnic. What is
Yeah.
tachypnic?
Short of breath.
Yes, sir. Exhibited decerebrate posturing. Do you see that?
I do.
And decerebrate posturing, you described that in your note, what you saw, right?
I did.
And incontinence of the bladder, that means she's urinating and she's unable to control the urination, right?
Agree.
Unable to follow commands, yet still conscious. Unable to follow commands, yet still conscious. That means that the patient is still awake, but
Agree.
unable to follow commands by you or another healthcare provider, right?
Yes, has not lost consciousness. Right. Awake.
Patient immediately moved to OR stretcher and taken to PACU at 10:34, Dr. Lee at bedside. Do you see that?
I do.
So according to Ms. Dudley's note, she suffered the decerebrate posturing and the loss of bladder control before she was moved to the stretcher, right? You see that? Legs, tachypnic, decerebrate posturing, incontinence of bladder, unable to follow commands. Patient immediately moved to OR stretcher and taken to PACU at 10:34. Do you see that?
I do see that, but I wouldn't read too much into that because that is a note, that is a summary note. Again, she's summarizing that at the time the note was entered, all of the things that did happen, even though I can read and understand the English here, the actual act of decerebrate decorticate posturing occurred after she was flipped. Those all things did occur. She was placed onto a stretcher and she was moved. But what I saw that day was she was flipped onto the stretcher. I saw the display and I was concerned.
Yes, sir. And you were concerned because in your differential diagnosis is a severe brain injury, right?
Possibility of brain trauma, yes.
And that was based on your training to observe neurological consequences of steroid injections, right?
Yes, agree.
And recovery department information, you see this. And we're still on page 21 of 33. See recovery in 1034. Do you see that?
I do.
And I mean, we're just talking about a few feet away. We're not talking about a different floor, different wing of the hospital.
We're
All
not.
this is in one, yeah. And it reads out 11:30. You see that?
I do.
So from the procedure room where you performed the epidural steroid injection until she left the PACU or the recovery room was close to an hour, right?
Yes,
56 minutes, 4 minutes shy of an hour, right?
I can agree with that.
Transferred out of facility. Discharge transferred to a critical care hospital. That happened at 11:30 on June 9, 2022.
Which matches the time of out of recovery. It
Yes, sir.
seems continuous, yes.
And she was discharged by you, and the discharge type was abnormal.
Yes,
And abnormal because of what you observed after the epidural steroid injection, the procedure, right?
that made it abnormal, but at the time of discharge, she was much improved. But yes, the incident, again, I'm not sure you're asking me to capture minute by minute or at a time that data is reported, you're asking me, is the summary correct? When people type in this type of information, they may be summarizing earlier events that occurred over several minutes. They might not be, you're using timestamps and saying, did it happen exactly at this time, at this time, at this time? Sometimes when a staff member enters in this data, they are summarizing that which had happened for a few minutes before, if that makes sense.
None of that minimizes the severity of decerebrate posturing, does it?
No,
Decerebrate posturing is a significant finding.
it can be.
Okay.
It is of concern and it requires acute medical attention.
Acute medical attention, right?
Right.
You said decerebrate posturing can be, a significant sign. I'd like for you again to name any treatise, textbook, chapter to textbook, peer-reviewed article, non-peer-reviewed article, grand rounds, throwaways, anything in medical literature that says anything remotely akin to decerebrate posturing is not necessarily a severe sign or a significant sign.
It is significant and it requires medical attention. Again, I tell you, there are examples of boxers that get knocked out and they display abnormal behavior and then they are taken away on stretcher without IVs and monitoring in place. There are examples of football players who go down and they display abnormal posturing. Again, they are attended to acutely for the change in condition, but IVs are not necessarily started right away. Monitoring is not done. All of those things are done for this patient, for this condition.
You just said medical care, but you testified a moment ago, you said acute medical care.
Okay, she got, the situation was acute and she got medical care right away.
Right, and by acute medical care, you mean to an emergency department, right?
No, I don't mean that. I mean to care for the changes that were seen. Again, if you look at the records, it talks about things like tachypnea, the decerebrate posturing, the straightening of the leg, the incontinence of the bladder. That was of concern. She was immediately taken care of, as evidenced by the continuity of care on the timestamps out of room 1034, placed at PACU 1034, a few steps away. Immediately, her most immediate acute medical needs, elevated blood pressure, high heart rate, shortness of breath, were all attended to right away in our PACU. That's what I mean by acute medical care. She got prompt and acute medical care for the conditions that she was displaying.
All right, you agree that,
Sorry,
oh, that's all right. Were you saying something? I just didn't
I
hear it.
was gonna listen to you.
You agree that as a physician, you have to take into consideration the entire constellation of signs and symptoms.
Absolutely, I do.
Signs you observe, symptoms you're told about in your patient, right?
Yes.
Decerebrate posturing, you saw it as just one of the signs, right?
Agreed.
And decerebrate posturing, you said, can be a sign of a severe brain injury, right?
Or not.
You can add or not to any can, right?
Okay.
Superfluous. It can be a sign or symptom of an acute brain injury.
It can.
Right. And incontinence of bladder, that's a sign separate from decerebrate posturing, right?
It points to some type of insult to the CNS, some kind of stimulus to the central nervous system.
Right. Potentially a head injury, a brain injury, right?
Potentially.
And you agree drooping on one side of the face is also a potential sign of a brain injury, right?
Insult, brain insult.
Well, and an insult can lead to injury.
It can lead to injury, but it's an
Good.
insult first.
You agree that hemiparesis or can also be a sign of a brain injury, right?
It can be.
In addition to these signs and symptoms, you also have to take an accurate clinical history, right?
Agree.
And the clinical history for Arlena Addison on June 9, 2022 is she showed up at OrthoAtlanta Surgery Center, right?
Agree.
According to the pre-op, all of her vital signs were within normal limits, right?
Agree.
She underwent a surgical procedure by you, right?
Agree.
Where you stuck a 20 gauge TUI needle into her cervical spine, right?
Into the region of the cervical spine. Yes, into the region.
A what?
Region, R-E-G-I-O-N, region.
Okay, into a region of her cervical spine,
Agree.
right?
Agree.
And that procedure lasted, let's see, 29 to 33, about 2 minutes, right? That cervical epidural steroid injection, your part when you're actually doing the procedure is about a 2-minute procedure, right?
It varies in time. I'd have to look at the timestamps, but it varies in time. Each individual episode varies in time.
You agree from 29 to 31 is between 2 and 3 minutes,
I
right?
do agree.
Okay. And so this patient, Arlena Addison, underwent that cervical injection into an area of her spinal column and her neck. And 90 to 120 seconds later, she exhibited decerebral posturing, right?
That is in my notes, so I do agree.
She has no history of decerebral posturing in her life, right?
I agree.
Not in your history, right?
Agree.
Right. She has no history of bladder incontinence, right?
Agree.
No history of a drooping face on the left, right?
Agree.
No history of weakness or tingling in her legs.
Disagree. She has long-standing history of lumbar radiculopathy, and it is associated with numbness and tingling to the legs.
So you associate her weakness and tingling in her legs after the decerebral posturing to her previous history of lumbar issues?
No, I do not.
Okay.
But she has those issues. That you are giving details of how she had all the negative history of all the other things. I was letting you know she does have a positive back history for which pain down the legs and numbness and tingling do occur.
Right, which never rendered her unable to walk or have difficulty walking, right?
She was always able to walk.
Right. Well, before this.
Yes, but she has had some difficulty in that pain down the legs can make legs feel tired, restrict distance of ambulation. Those kind of things can happen as a result of the diagnosis of lumbar radiculopathy.
So when you're making a diagnosis or even differential diagnoses from which you make a diagnosis, you take into account all these signs, symptoms, and the patient's history, right?
I do.
Okay. And you did all those things on June 9th.
I did.
And after you did all those things, she still waited in the PACU for 56 minutes before she got, before she was transferred to the hospital for a higher level of care, right?
All that is true, but as my medical record reads, a lot of the things that happened immediately post-procedure, including the neurologic deficiencies in those 56 minutes, cleared up completely. The thing that was residual was a slight droop to the right side of the face. Her complaints of my lips feel numb and I still have tingling in my legs. So those things that you're describing to me did occur. They did occur within 90 to 120 seconds post-procedure. I appreciate you telling me that 56 minutes had passed. In those 56 minutes that had passed, she was given immediate care to take care of her immediate needs, including things, as you mentioned, like faster heart rate, faster breathing. All of that was being attended to her in our PACU. While she was being attended to that, throughout those 56 minutes, her vital signs improved, her neurologic condition improved. You make notes of things like difficulty following commands immediately post-procedure. I'm sure those things did occur. In those 56 minutes that you are talking about, all of those neurologic deficiencies, save for the ones that I mentioned. You are asking me as a clinician, do I count a differential diagnosis? Do I take history, physical examination into account? I do all of those things. And at 50 some minutes into the PACU, she had cleared significantly. The vital signs had normalized. She was no longer complaining of any significant pain. Again, my notes reflect my conversation with her.
Yes, sir. And in those 56 minutes, she also began suffering from new signs and symptoms, right?
Can you name those for me so it would?
Sure.
Go ahead.
Well, the droop of her mouth, you said it was on the right, not the left? Was it on the right or the left, if you remember? Or
I
if you-
don't remember.
You're welcome to refer to your notes.
I don't know if I recorded left or right, sir.
I think you just testified right, though.
Okay, I'll read my note.
And what are you looking at now for the record?
My operative note?
Anything else?
Nope, just the operative note. So it would have been the left side. that
Okay,
was drooped.
that's fine. When you
Okay.
testified right side earlier, you just misspoke, right?
I think so. It's been a long day.
But that drooping of her mouth on her left side, that was a new sign or symptom that occurred between 10:34 and 11:30, right?
It was not noted immediately. It did occur sometime thereafter, and it became of concern.
Okay. Same with the left-sided weakness. That occurred between 10:34 and 11:30, right?
Yes,
Same for the leg weakness and tingling. That occurred between 10:34 and 11:30, right?
I don't know if, yes, what I'm saying is that the overriding clinical presentation of decerebral posturing, as that improved, it allowed us to further assess what underlying conditions may have existed. I don't know that something de novo new had come up. In other words, the clinical presentation can change based on improvement. And if this is better, then you might notice something else that's underlying, if that makes sense.
It does. At the same time, you just testified a moment ago that, by the time she left OrthoAtlanta, was headed to the hospital, this stuff had cleared up, and that's not quite accurate, is it? You may answer.
Oh, I don't know about quite accurate. I do know
It's
that
inaccurate. It's wrong. That does
she had
that does not paint an accurate picture of what happened.
she significantly improved by the time of discharge.
Okay. When the emergency call, you heard it earlier, 10 minutes in, before the emergency, before 911 was called, at 10:44 to 10:47, that she wasn't getting any better. Remember that?
She had persistent clinical presentation of concern that required activation of EMS.
Okay. By activation of EMS, you mean calling 911?
I do.
This is Miranda Dudley, registered nurse, 6/9/2022 at 10:34 to 11:30. That's the recovery or PACU, right?
Yes,
And by PACU, you mean post anesthesia care unit. Is that right?
yes, yes.
Recovery assessments, this is where you agree the vital signs were different from when she came in, but her vital signs at least were better by the time she was transferred, right?
Yes,
You see, this is page 24 of 33.
I do.
Her blood pressure is now 182/106, right?
And we are acutely trying to get that down in
I
the
understand.
PACU unit. Okay.
I mean, I hope you, I mean,
Yeah, that's,
surely you were, yeah.
yeah, okay.
Her pulse is now 165, right?
Mm-hmm.
Yes, I know we all do that.
Yes, sorry.
Yes. And you agree that anything over 100 in an adult is called tachycardia, right?
Agree with that.
So she was tachycardic. Her respiratory rate has doubled, right?
Yes,
It's up to 36.
yes,
And a normal respiratory rate is between 18 and 20.
agree.
And ECG rhythm, ECG stands for what?
Electrocardiogram?
Yes, sir. And sinus tachycardia, what does that mean?
The heart is beating in a sinus rhythm, but it's moving fast. Sinus rhythm is normal rhythm. It's just moving quickly.
And she's also on supplemental oxygen.
I see that.
Is that right? Well,
I-
I know you, I
yes,
know we both see
It
that.
is right.
I'm
It is
asking-
right. It is right.
Yep. I'm gonna go on down. You see, this is a PACU recovery note by Miranda Dudley. This is at 2 o'clock in the afternoon.
Can I say I see that or what the?
But you agree with that?
I agree with that. I agree that it is a recovery note.
And who was providing the supplemental oxygen?
I could not tell you the name of the team member who put on the mask.
Do you recall having a conversation with Arlena's daughter, Hillary?
I may have briefly talked to her on the phone that day.
Do you recall sharing with her that you saw air in the brain?
No, I don't recall that statement.
Okay.
Because you can't see air in the brain on fluoro, and the only way that would have been determined is with advanced imaging at the hospital. So I did not personally see it, as I did not see those images.
All right, so we're on page 25 of 33. This is Miranda Dudley, patient to PACU at 10:34. That matches all the other notes, right?
It does.
Noted to be tachypnic, tachycardic, rigid body. Rigid body is a sign of decerebrate posturing.
Similar to, yes,
Unable to FOC and incontinent bladder.
follow commands.
FOC is follow commands, is that right?
It is.
Sir. NRB, 100% applied. What is NRB?
Non-rebreather mask. It's a way of applying 100% oxygen,
Supplemental oxygen. Right?
supplemental oxygen.
As well as continuous cardiac monitoring. Dr. Lee at bedside, that's you, right?
It is.
Anesthesiologist, Dr. Sub at bedside to assess patient also. Unable to get accurate pulse ox reading due to clenching of fist and rigidity. Do you see that?
I do see
You
that.
agree with that? Do you remember that?
I agree with the note that I see.
Yeah. And have you ever had a patient that you were unable to get a pulse ox on because their fists were clenched so tight?
This would have been a first.
Yeah. And well, this is your first experience with decerebrate posturing too, right?
Yes, it is.
Clenching of fist and rigidity, also a first, the rigidity part, right?
Yes,
And you agree that for your patient safety, it's always better to have someone with more experience regarding a patient's condition, if that person's available, right? If that physician's available.
yes,
In other words, you had no experience with decerebrate posturing. You know, if there were physicians, acute care physicians with experience in decerebrate posturing, you would want, for the benefit of your patient, her to be in the care of that physician, right?
Highest and most experienced level of care, yes.
Yes, sir. Attempted to get EKG, unable due to artifact from shaking. Do you see that?
I do.
Have you ever had a patient who was shaking so much you couldn't get an EKG?
This would be in the first, but this
Yes.
is all, can you give me the timestamp that this is occurring, please?
I'm just looking at the notes.
Okay,
It's before transfer. It's between 10:34
10:34.
and 11:30. I'll tell you
It
that.
says patient to PACU 10:34 and following commands at 10:47, 10:52. There are, in this note, it does appear that manual entry for timestamps. This isn't like a computer timestamp, best I can tell. It's something that was typed in by someone who took careful notes. So, you know, these things, when the patient gets to the PACU at 10:34, these things are occurring at 10:47. So that's 13 minutes in. And then some of the other things you're reading is 10:47, 10:52, and it's still exhibiting. So that's been 18 minutes, close to 20 minutes. Yeah, 20 minutes at the 10:52 mark.
And your point is what?
Oh, I'm letting you know that these things are occurring, and I'm just trying to, I'm not making a point. I'm trying to clear it in my mind as to when these things are occurring after the original event. I'm not making.
These things are occurring between 10:34 and 11:30, right?
Well, if these timestamps are
Sir,
correct.
first I want to answer my question, then you can,
Oh,
as
sorry.
long as you want. yeah.
Okay,
All these are occurring according to the medical record between 10:34 and 11:30, right?
yes.
Okay. Now you can go ahead and talk away.
Oh, well, in that statement, I wanted to unpack it and just talk about the different times that are reported, and because she had had those symptoms, even though she was improving, and I had seen what had occurred and I remained concerned, I wanted her to go to the emergency room. Yeah.
Dr. Lee advised to call EMS. EMS called at 10:47. Do you see that?
Yes,
Okay, so you call EMS 13 minutes after 10:34, right?
yes, yes.
And for those 13 minutes, you didn't think EMS needed to be called, right?
No, I didn't say that. What I would say is that we were attending to her acute needs for the first 10 to 13 minutes.
Okay.
That's what I would say.
It looks like here at 10:47, patient still unable to follow commands, right?
I see that.
You agree with that? It's similar to what you recall?
Yes, and again, the reason to call EMS as they are now en route because of the persistence. Yes,
10:52. Now that's 18, nearly 20 minutes, right?
yes,
Patient still exhibiting rigid position. Do you see that?
I do. I do see that.
So that's still decerebrate posturing at 10:50?
No, it had cleared in the arms and the legs were still straight and tight and down going.
All right. Shaking but able to answer yes or no questions and states her legs are tingling. Do you see that?
I do.
Driver Shea notified of pending transport by Dr. Lee and pending transport by Dr. Lee. In other words, you talked to the driver and said, you're not going to be able to take her. She's got to go,
That's right.
right?
That's right.
And daughter Hillary called and notified of patient status. Was that, did you talk to Hillary then?
I may have, I couldn't accurately answer that.
Okay.
I have talked to her before, but I don't know if it was on the exact. I do recall something about her voicemail being full, so that's why I don't have accurate recollection.
EMS arrived at 11:08. Report given, patient awake and able to follow commands at this time. Do you see that?
I do.
Refuses to go with EMS, but states legs are still tingling. Dr.
see.
Lee at bedside to speak with patient. Patient agreed to be transported to Cobb after speaking with Dr. Lee and transported by EMS at 11:30, right?
I see that. I agree.
And you told her she absolutely had to go to the hospital, right?
Yes.
Okay. That was because of what you'd been observing for close to an hour, right?
Yes.
And she had a number of classic signs for brain injury, right?
Trauma to the brain. Yes.
All right. These are your discharge instructions, page 29 of 33. I'm not gonna, we can go over that at trial. Op notes, this is page 29 of 33. Physician Wiley, preoperative diagnosis, postoperative diagnosis, the same, right?
Agree. Right. Correct.
Proceed. You, you can choose one. You don't have to say all three. Thank you, though. All right, so we've got, this is your op note. And this here, I'm gonna pull a different one just so we have it on one page. I think it'll make it easier. Is this number 10, Madam Court Reporter?
That's correct.
You proud of me? Show you what's been previously marked as Exhibit 10 to your deposition. This is your operative note regarding, whoop, wrong one. This is your operative note regarding Arlena Addison.
I can't see the top of it. Sorry.
Hold on. All right, so this is page 29 of 33. This is the top of your op note, right?
I recognize that.
Op note, Wiley MD. This is still Arlena Addison. June 9, 2022. Do you see that up in the top right corner?
Yes,
It goes on to read, this is page 30 of 33. This is a continuation and conclusion of your op note, right? Operative report, right?
mm-hmm. Yes, yes,
Thank you. Anesthesia, IV conscious sedation with use of Versed and or fentanyl, and it was actually both Versed and fentanyl, right?
yes,
Indications for the procedure to relieve neck pain and arm pain, right?
yes,
Description in detail. After an informed consent was attained, the patient was taken back to the fluoroscopic suite. That's the procedure room we've been talking about, right?
yes.
And the prone position is what? Face
On
down.
the belly, face down.
Attached to the patient were a blood pressure cuff and pulse oximeter, which we utilize to monitor the vital signs. You see that?
Continuous monitoring of vital signs. I see that.
Well, yeah. So when you took her back to the procedure room before the procedure, you had no problem monitoring her blood pressure, right?
None.
And no problem taking her, getting her oxygen saturation by a pulse ox, right?
Agree.
You had both those problems immediately after the procedure. She was shaking so bad you couldn't get her blood pressure, and her fists were clenched so tight, and she was so rigid that you couldn't apply a pulse ox, right?
The blood pressure, I'm not sure about. I thought.
Sure,
it
I'd
was
like
more
to
like-
answer my question, then you can talk then you can.
Not sure. Not sure about the blood pressure. Not sure if we were able to get a blood pressure or not.
You don't remember being able to get a blood pressure before her procedure?
No, I definitely remember being able to get a blood pressure before. I thought your question was afterwards, was she able to get a blood pressure because of the rigidity? And my thoughts are that she may have already had a blood pressure cuff on. And if so, it may have been taking blood pressures, are my thoughts.
Let's go back to the note we just reviewed.
Okay.
You see, this is again on page 25 of 33. Can you see that all right?
I can.
Okay. It reads here, this is Miranda Dudley.
Yes,
6/9/2022, 14/19. This all, as you testified, occurred between 10:34 and 11:30, right?
yes,
This is after the procedure. What we were just talking about, your note is before the procedure, right?
yes.
Unable to get accurate pulse ox reading due to clenching of fist and rigidity. Do you see that?
See that.
Attempted to get EKG, unable due to artifact from shaking. Is that right?
Yes.
Is it your understanding that notwithstanding the shaking, they were able to get a blood pressure after?
I understand the lack of O2 monitoring and EKG per this statement. I
Yes, sir.
said I didn't understand about whether or not blood pressure was obtained. I don't see that in this statement. That was what I was getting at.
Okay.
You asked a specific question about blood pressure, and in my brain, I'm thinking, well, we probably had a blood pressure cuff on her, and I don't know if we were getting blood pressures. This doesn't talk about blood pressures here.
You're right. You're right. That was my question. So we'll go back to your medical record. You agree that you were able to get her, you were able to get both her blood pressure and her pulse ox prior to the procedure, right?
I do agree.
And you were unable to get her pulse ox after due to clenching fist and rigidity, right?
Agree.
And that was a first for you, right?
Yes.
Okay. Through the IV, the patient was given Versed and fentanyl to titrate for pain control and provide comfort during the procedure with use of fluoroscopes, C6-7. Disc interspace was identified just in the midline. That's what you wrote.
Yes.
The skin was marked. The skin was cleansed, prepped, and draped in a sterile fashion. Now, the skin was marked not in the procedure room, in another room, right?
Pre-procedure.
All right. And the skin was cleansed, prepped, and draped in a sterile fashion. That happened in what room,
The procedure room.
sir? The injection site was injected with approximately 3 milliliters of 1% plain lidocaine solution. That's the first thing you did, right?
Subcutaneously through the skin and muscle layers.
Yes, sir. That's a local anesthetic, right?
Yes, it is.
After adequate anesthesia, and by the anesthesia, now you're talking about the Versed and the fentanyl, right?
Along with the topical local, all are forms of anesthetic to reduce pain, all are forms.
Thank you. With use of a 20 gauge 2E needle connected to loss of resistance glass syringe, cervical epidural space was entered. That's what you did.
Yes,
Negative aspiration was confirmed, right?
that is use of negative pressure on the syringe to make sure that there is no fluid coming back. That increases the confidence that the tip of the needle is not into the dural space. That is important as to withdraw the plunger to create negative pressure in the chamber to see if it'll suck up, much like a vacuum cleaner, to see if it'll suck up fluid. None came back.
Okay, and that when no fluid comes back, that tells you what?
It increases it reassures me that the tip of the needle is indeed in the epidural space and not through the dura.
And if it was through the dura, you would expect what to happen with the syringe?
CSF, fluid to come back.
After adequate anesthesia, use of 20 gauge 2E needle connected to loss of resistant glass syringe, cervical epidural space was entered, negative aspiration was confirmed, and in the cervical epidural space was infused a solution containing 3 milliliters of 0.9% preservative-free normal saline, along with 20 milligrams of dexamethasone, right? That's what you inject.
Yes.
Patient tolerated the injection, but 90 to 120 seconds after the injection, patient expressed discomfort. Is that right?
Yes.
You remember how she expressed discomfort?
It wasn't verbal. It was through the motion. That was what I witnessed.
All right, so she expressed it by the decerebrate posturing.
Agreed.
She displayed transient decerebrate posturing, parenthetically, arms upward, fists clenched, back arched, legs straight, and feet and toes down going.
Yes. Apparently.
That's what you observed.
Yep.
What? I'm sorry, I just didn't hear you.
Yes. Yes. Yes is the right answer.
She was noted to have involuntary loss of bladder function. You recall that?
Yes.
She remained conscious and alert, stating she had a hard time breathing and her legs felt numb. You recall
She
that?
verbalized that to me. I do recall her verbalizing to me.
Okay. She was transported to the PACU with continuous monitoring of the vital signs and high flow supplemental oxygen. Anesthesia was called and she had continued supportive care for 10 minutes. Her vital signs were found to have elevated blood pressure with tachycardia. EMS was activated and transferred to Caldwell Star Hospital was initiated. Patient stated that her mouth felt funny and tingling. You see that?
I do see that.
And that's all in the first 10 to 13 minutes.
Best I can recollect. Yes.
Approximately 5 minutes later, with additional supportive care, she became more responsive and was able to breathe without supplemental oxygen. Her vitals were then normalized. Is that right?
Yes.
Do you recall about what time her vitals normalized?
I would have to refer to the flow chart to see that.
Okay, and this is, for the record, this is page 30 of 33, right? Where your note is?
Yes, I see 30 of 33. I see that.
So if we scroll back up to the vitals, do you see here page 24 of 33, and it working backwards, 23 of 33,
I see that.
22 of 33, 21 of 33. So working from 24 of 33, blood pressure 182 over 106, Pulse 165, respiratory rate 36, not normalized, right?
No, not normal.
And that was at 1036. 1041, still not normalized, right? 167 over 98, heart rate of 148, right? Respiratory
Yes,
still 30.
yes,
And oxygen saturation 86, right?
I see that.
Okay, not normalized, right?
No,
1051, still not normalized. Because heart rate, blood pressure 163 or 122, pulse rate 120, still tachycardia, still tachycardia, exhibiting tachycardia. At 1051, her blood pressure is 163 over 122, right?
yes,
Heart rate 120, right?
yes,
Respiratory rate 41,
yes,
still not normalized, right?
right,
1055, blood pressure 138 over 98, still high, particularly based on her baseline, right?
yes,
Heart rate now 110, still tachycardic, right?
yes,
Respiratory rate 28. That's still 8 to 10 breaths per minute higher than a normal, 18 to 20, right?
mm-hmm,
Is that a yes?
yes, yes,
It's still not normalized, right?
yes,
Now it's 11:01. And now the ambulance gets there at 11:01. Her blood pressure is 135 over 82. Heart rate still tachycardia 104. Respiratory rate 23. Do you see that?
I do see that.
Still not normalized, right?
Trend is improving, still not normalized.
Okay. So now 11:06. Blood pressure 122 over 121 over 79.
Mm-hmm, yes, yes,
And that's within normal limits. Hello?
yes, I said
Oh,
yes.
I lost you. You, your screen froze.
Oh, okay,
Pulse rate 95, high for her, but at least she's not tachycardic now, right?
yes,
Respiratory rate 21, that's pretty close, right?
yes,
So would you say by 11:06, has she normalized at 11:06 or not?
yes,
Okay. So that's about half an hour after the onset. Is that right?
yes,
Back to your notes. Back to page 33, I'm sorry, 32. Page 30 of 33, the balance of your note. You recorded this note on June 9, 2022 at 11:11, right?
yes,
Patient tolerated the injection, but 90 to 120 seconds after the injection, patient expressed discomfort. She displayed transient decerebrate posturing. It's going down. You wrote her neuro deficits resolved. See that?
yes,
Is it your testimony her neuro deficits had resolved by the time she was taken to the hospital by ambulance?
save for, I specifically recall asking her to smile. I did note a slight facial droop. I asked her, are you having any other conditions? She said, I feel persistent numbness in her lips and her toes were numb. I think that is when I asked those questions.
All right.
I did both. You were saying about histories and physical examination, so I was attempting to do both. I was attempting to talk to her and examine her at the same time.
You agree that with those symptoms, her neurodeficits had not resolved, right?
Not completely, no.
Okay. Yet you wrote they had resolved.
Majority, I should have wrote the majority of which, yeah. I compared to rigidity and stiffness, those things had resolved. The decerebrate posture, the rigidity, the legs all had resolved. There were, because at that time in real time, I was talking to her, was asking her, do you have anything still going on? My lips are numb. I asked her to smile. There was a slight facial droop noted, and she said her legs were tingling. But the vast majority of the neurodeficits, as I had recorded earlier, had resolved.
All right. She stated, I'm okay. I hope I didn't scare you. You see that?
I do see that.
Did you, do you recall her being a kind patient?
I do.
Do you ever know her to be unkind
No,
or create any issues as a patient for you?
no,
Transported by ambulance in stable condition.
yes.
You consider her condition was stable. Is that
I
right?
did consider it stable because the vital signs had improved and the neurologic deficits were largely resolved, There was still enough concern that it was my clinical judgment that she needed further evaluation.
Right. Would you ever, I mean, if your patient, like she did, experienced decerebrate posturing over the course of a cervical epidural steroid injection, would you ever not send that patient to the hospital?
I don't know what I can force a person to do, but I would strongly recommend it. It's my
Right.
strongest recommendation, is what I would say to the patient.
And that's because decerebrate posturing is a potential sign or symptom of a brain injury, right?
Agreed, potential, agreed.
That's irrespective of the mouth drooping, the loss of bladder control, all those other things that were in addition to decerebrate posturing, right?
I don't know. That's outside the scope of my practice. I know that decerebrate posturing plus the other things that I noted are all of concern. You said outside of was a part.
No, that's, I mean, that's a fair explanation.
All are of concern to me, sir. All are of concern to me.
Yes, sir. Attempt to contact daughter on phone, but got message that voicemail was full, contacted friend who drove her to the center and informed her of the transfer to hospital ER. That's the end of your note, right?
Yes, it is.
All right, it's 3:00. We'll take a short break. 5-10 minutes, all right? Thank you.
Going off the record at 2:59 p.m. We're back on the record at 3:09 p.m.
Do you remember the last, you mind reading back just the last question or answer or part of it?
You're at the end of his note. So.
Okay. Still exhibit 10. No. think it's not. Let's see. Still exhibit 9, I believe it is, which is a medical record. This is, if you see on the lower right, 49 of 52. This film, this is the same film we reviewed earlier. Arlena Addison, June 9, 2022.
Yes.
Is this 11?
That's correct.
Thank you. Show you what's been previously marked as exhibit 11.
Thanks.
This is the incident report for Arlena Addison. Again, dated June 9, 2022. You see that? Oh,
I can see that.
okay. The time of that incident, this is 10:32 that morning. Brief description. Procedures C67 midline, ESI, SIP here. Can you read that?
No.
All right. 3 milligrams Versed, 50 micrograms fentanyl. Patient became rigid, tachypnic, tachycardic, and was unable to follow commands approximately 20 minutes following ESI. You see that?
I do.
And is it your recollection that she exhibited these signs and symptoms for approximately 20 minutes?
In a resolving fashion, not all of the signs were equally prominent at the 20-minute mark, but for 20 minutes, some of those things persisted. In other words, if you read right before that, it says things like rigid, tachypnic, tachycardic, and unable to follow commands. That's a lot to unpack. And previously in testimony, you went over a timeline, particularly the vital signs, in which you talked about how long it took for vital signs to come back to normal. So I would rely on that document in terms of things like rigidity and unable to follow commands. There was previous documents that talked about unable to follow commands, and there was some time stamping there. So my opinion is that that whole thing has been grouped together and 20 minutes has been assigned to it. In real time, each of those parameters are changing, and not all parameters are present at 20 minutes.
All right. You would agree, though, when we looked at the medical record, which I can pull back up, her vital signs didn't normalize until after 11 o'clock.
I recall that, but in addition to vital signs, there are things in that statement: rigidity, unable to follow commands. And my question or concern is, I don't know that those things lasted a full 20 minutes. Rigidity and unable to follow commands is my concern.
I mean, when someone suffers from decerebrate posturing, I mean, in addition to other signs and symptoms we've gone over today, I mean, whether it's 18 or 20 or 13 minutes, while that's significant, the bottom line is, you know, this constellation of signs and symptoms with her clinical history is of major concern, right?
It is, and we attended to her.
And it's a potential sign and symptom. These are potential signs and symptoms of a severe brain injury, right?
Potentially, yes. I could not make that diagnosis. I'm not qualified, and a lot of that diagnosis, when you use the term injury, depends on imaging studies to show the injury. And that's not known to me at this time, at the time of the.
Yeah, and it's known to you now, right?
Sir?
Yeah, that was done at the hospital by other physicians, right? Can you hear me?
I can hear you.
Yeah, the imaging, what you suggested, that your lack of training and other physicians with
Have that
different
imaging, right. I don't
expertise
have that
and
imaging.
imaging, all those things at the hospital, that was done by other physicians at the hospital. Right?
Yes, yes, other physicians at the hospital.
And you've reviewed those records or you have not?
No, I have no formal review of those records.
Yeah. And we're still on exhibit 11, I believe it is. The the first page, treatment or procedure variance. You agree that Arlena Addison, this was an unplanned acute care transfer, right?
I agree.
Medical treatment was, she was taken to the emergency room.
I agree.
Nature of injury sustained, unable to determine.
I agree.
Severity level, major injury, incident is potentially life-threatening, immediate physician or nursing intervention. You agree with that?
I do. And it was provided for her at our PACU, and continuous medical care was provided through EMS transport and picked up by the emergency room.
Yes, sir. And the witnesses, it was the three of you, Nurse Dudley, Nurse Doyle, and yourself, Dr. Lee, right?
Yes,
The employee preparing the report, that was Miranda Dudley. That was around 11:30 that morning,
yes,
June 9, 2022. Your physician's orders, do you see these? This is page 4 of 8 of Exhibit
I
11.
see them.
6/9/22, 10:50. This is right before she's transferred. Transfer to emergency room. Continues suggested or supplemental O2 oxygen, and continuous monitoring of vitals. Is that right?
Yes,
Do you recall attending a meeting regarding Arlena Addison after she was transferred?
it is our custom and practice at our surgery center, should such an event occur, that we have a team huddle debriefing.
Yes, sir. And you were at that team huddle debriefing?
Yes,
And were you able to determine what was not done that ought to have been done?
no, I was not able to determine.
Okay. But tell me everything you recall about those discussions.
It was along the lines of, she got taken back, she had all of the appropriate pre-checks done during the procedure. Appropriate doses of medications were given. When was first time duress was identified in patient? It was after the procedure was 90 to 120 seconds completed. At any time during the procedure, did anybody notice any type of duress that would have halted the procedure? None was voiced. And at what time was duress noted? It was after the needle was removed and the patient was flipped over, is when duress began. And then with duress, what all did we do? We immediately identified it as a situation of duress to take her back to the PACU. Advanced providers, including anesthesiologists, CCU nurse, were available. Vital signs were carefully monitored. Acute medical care was provided in the form of high flow supplemental oxygen, continuous monitoring of vital signs. And however many minutes later, although vital signs were improving in scope in total of what had happened, EMS was activated.
This is page 6 of it, tertiary care unplanned admission, Arlena Addison. You see that?
I do see that.
And it reads here, reason for transfer, transport, rigidity, seizure-like activity.
I see that.
That's your signature.
That's my name. That's not how I sign it.
You agree that she was transferred for, at least in part, rigidity, seizure-like activity?
For having displayed it. Yes, I do agree. She did display that.
And someone else wrote your name here. I assume it was Miss Dudley.
Okay.
I don't know. I mean, this is.
Yeah, I don't know either. I don't know who wrote that, but that you asked, is that my signature? It is not my signature.
Yeah. Says the decision to transfer, which was yours, emergency transfer. Excuse me. And the last page, this exhibit, nurse report sheet. Excuse me. Current medications, procedures, C6-7, Midline ESI, surgeon Dr. Lee. Reason for transfer, seizure-like activity noted, loss of bladder function, tachycardia, left-sided mouth drooping, loss of body control, rigidity. You agree those were, among others, reasons for her transfer?
I agree. All of those things did happen post-procedure.
Yeah.
Along a timeline.
What was that last part, please?
Along a timeline. I want to be clear that at the time of transfer, those things were not actively occurring.
Okay.
From 10:34 until 11 or whatever your timeline is, all of those things did occur during that time frame. At the time of transfer, not all of those things were happening, is my point.
Yes, sir. Show you what's been previously marked as Exhibit 12.
Affected. Oh.
Exhibit 12 is a transfer to tertiary care facility, policy number CL 46 policy. It is recognized that it may be necessary to transfer a patient to a tertiary care facility for acute care services and or an overnight admission that is not offered within the center. This is a policy you employed regarding Arlena Addison's transfer, is that right?
That's right.
And 11, after the patient leaves the center, review the situation immediately with the personnel that were involved in the patient care scenario and ensure that everything is documented. Is that what you did?
Yes, that was the team huddle.
To show you what's been marked is, this is 13. Does this accurately depict a vertebra?
It looks to me to be a cervical vertebrae. There are so many vertebrae in the body. It depends on what level is in question.
Yes, sir. Maybe I can do a better job. Does this accurately depict a portion of the spinal column?
Agreed, but because the spinal column has a cervical and thoracic and a lumbar region, each of those regions have different size and shape of vertebrae.
Yeah, I understand all that.
Okay,
This is, do you see where there are a number of indications regarding what these various parts are called? Do you see that?
I do see that.
You see epidural space?
I do see that, but
You agree that that accurately depicts an epidural space?
I would be more confident in my statement if I knew if that were a cervical, thoracic, or lumbar region, that image. I don't know, that image is not labeled a cross-section of what part of the spine. The vertebrae of the neck, the mid-back, and the low back are all different. They have different morphology, shape. Unless this is labeled, I don't know. The first question is, what part of the spine are we talking about?
Well, Arlena Addison's cervical spine is not labeled, was it?
No. But
Okay,
this diagram is labeled, and as part of the labeling of this diagram, I would like to know what portion of it illustrates.
all right. Well, if you can't answer the questions about this one, I'll just leave it as an exhibit and we'll deal with it later. Is that your testimony? Well, you can't tell me whether that's an epidural space because you don't know what, whether it's part of the cervical spine, thoracic spine, or lumbar spine, right?
There are nuances and differences of the epidural space, but because it is labeled epidural space, I have no objection to it being labeled as epidural space. The diagram appears to be accurate, but my first question would still be, what region of the spine are we talking about?
I'm talking about the cervical spine.
Okay, if that, it's not labeled cervical spine, but if this is your presentation of a depiction of the cervical spine, I can agree to that, but it's not labeled as such.
All right. You agree that what is marked epidural space, this accurately depicts the epidural space.
Okay, I will agree.
Okay. And the epidural space, is that where you want to make your injection?
Yes,
All right. And you see immediately beneath that where it reads subdural space?
I do.
And that's immediately beneath the epidural space, right?
Agreed.
And the subdural space is where the cerebral spinal fluid and the spinal cord are located, right?
Agreed.
Okay. Then there's a subarachnoid space. You see that?
I do.
And the subarachnoid space, that is where the spinal fluid is housed. Is that right?
Agreed.
Okay. And then same portion of the spinal column, pia mater, that's part of the spinal cord itself.
It's the coating of the spinal cord, the most closest adherent layer.
Okay. And the arachnoid, this accurately depicts the arachnoid, that cover where the spinal fluid is housed, the cerebral spinal fluid.
It's next further out, and the picture seems to show it's the next structure away from the spinal cord.
Yes, sir.
It would be correct.
And the dura mater, dura mater. I mean,
Fine. I
and
understand you.
And that's the part that protects the cerebral spinal fluid and the spinal cord beneath the epidural space where you're making the injection.
I would agree with that.
And that's accurately depicted here.
It seems to be.
Okay. And you agree that where it reads bone of vertebra, that accurately depicts what would be a bone or vertebra?
Yes.
And that is the spinal process on the back. It's not labeled, but that's a part sticking up in the top.
Yep, I would agree.
And the body of the vertebra, that's the bottom oval shaped portion, right?
I would agree.
Show you what's been previously marked as exhibit 13,
14.
14. Thank you. And this is another diagram. And do you see where it reads C2, C3, C4, C5, C6, C7?
Now I'm more comfortable knowing this is the cervical portion of the spine because it is appropriately labeled.
Yes, sir.
Okay.
And you see where the C2 to C7, the C stands for cervical, right?
Yes.
And that's, while this is cut in half,
Sagittal.
thank you, sagittal, it's got the opening between the spinal column and the spinal processes on the back, right?
I see the opening.
Yes, sir. And it reads here, ligamentum nuchae. You see that?
Yeah. Yes, I see that.
Interspinous ligament,
Yes.
ligamentum flavum,
Yes.
mentioned earlier. You have to go through all those things to get to the
Epidural space.
the epidural space where you want to make the injection. Thank you. Right.
Sure. Yes. Agreed.
And this accurately depicts the ligamentum nuchae, the interspinous ligament, the ligamentum flavum, and the epidural space, right?
Yes.
Also accurately depicts the supraspinous ligament, right?
I see that.
And you've got to go through the ligamentum nuchae, the interspinous ligament, the ligamentum flavum, and the supraspinous ligament to get to the epidural space, right?
Yes.
Yeah, you've got to go through all these to get where you need to be, right?
Yes. Yes.
And it also depicts the spinal dura mater, which is immediately beneath the epidural space, right?
Mm-hmm. Yes. Yes.
So you've got to go through all these and stop in the epidural space without going into the spinal dura mater, right?
Yes,
And that's because beneath that spinal dura mater is where the cerebral spinal fluid is, right?
yes, along with the pia arachnoid matter, the dura mater, the arachnoid matter, and the pia mater.
Right. And the cerebrospinal fluid, in addition to bathing the spinal cord, it also bathes the brain, right?
It does.
So what's been marked as plaintiff's exhibit 15. Now, this is another diagram of an injection process in the spinal column. Do you see that?
I do, but again, I make note, this one is not labeled what region of the spine we're in. See, cervical, thoracic, or lumbar. Your first picture didn't note a region. The second picture did. It had the C's in here. Unless I see if this is cervical, thoracic, or lumbar, I'm not sure what part of the spine I'm in.
Well, do you
Oh, I see the C's. Okay, I'm good now. Okay,
That's
I do
okay.
see the C's.
That's okay.
Yeah, that helps. I just want to be clear for
Yes,
my
sir.
reference. Yeah,
And also these spinal processes on the cervical spine look a lot different than on the thoracic and lumbar, right?
I don't disagree with anything, but I would like, once you showed me the Cs, I'm okay now. Yes.
So you agree this accurately depicts the spinal column, the spinal cord, and at least C6, C7, which is where you were doing the injection,
I
right?
do agree.
And do you mind taking a moment, just have a look at these labels, and do they accurately label what's depicted here?
Can you enlarge, sir?
Sure. You may start on the left or right or top or,
That's good there.
well,
A
here,
little smaller.
let me make it bigger so you can see.
Yeah,
it.
yeah, that'll be good. Thank you.
Yeah. Been a long day.
Okay, that's fine. I can see everything and I can read everything. Okay,
You tell me when you're ready to move.
I'm ready to move.
Okay.
I've had an adequate time to look at the pictures and the labels.
All right. And does this accurately depict what it claims to predict? The vertebral artery, the epidural fat and plexus, the dura, the ligamentum flavum, etc.
Uh-huh. Depict is the word you use. Yes, depict. I'm having a hard
However
time.
you want to say it. What I want to know is whether
Okay.
this is accurate. Does this, and I know we're all different as far as
I want to be
structure
exact.
and anatomy, but
Okay.
does this accurately depict what a spinal column, spinal cord, dura, what's depicted and described here? Does this appear to be accurate to you?
Yes.
And these needles that are, what one is going in posteriorly or through the back of the neck, and one is going in laterally. Is that right? On the side?
Yes, it is.
I think I'm on Exhibit 16, is that right, Madam Court Reporter?
That's correct.
Show you what's been previously marked as Exhibit 16. This appears to be the policy and procedure regarding operating room readiness. You seen that before?
I have seen the document before today.
Okay. To establish operating room readiness policy number CL 21.0, you agree that, I mean, it's important to comply with the policies and procedures here at OrthoAtlanta Surgery Center, Austell.
I agree.
Purpose to establish guidelines to acquaint clinical personnel with the need to be ready at all times to render surgical intervention. All patients will receive quality care through readily available equipment in each operating room. You agree with that?
I agree.
You're there to give quality care, right?
Yes,
Prior to commencement of the daily operative schedule, all equipment should be checked and tested for proper safety and functioning, right?
I see that.
And you agree that accurate timestamps on a C-arm would be included in proper safety and functioning, right?
No, again, that is not a safety. The C-arm should function. It should give adequate radiation to create a picture on my screen so that I can see it. That is falls under the category of safety for quality care. Yeah.
You agree that radiation can be dangerous?
Yes.
And the reason the C-arm film and the C-arm tracks the amount of radiation exposure over the course of a procedure is because you can give a patient too much, right?
Yes.
And that can be dangerous to your patient, right?
Yes. Yes.
Yeah, and the way that's monitored by the C-arm is the time of radiation exposure, is it not?
I don't know. I don't know.
Okay. Well, you agree that the C-arm, one of its functions to ensure that you're safely caring for your patient is to let you know if you get to a dangerous level of radiation exposure, right?
Yes, it does beep at a certain level.
Right. And the way it tracks that is by the time of that exposure. Makes sense, right? I mean, if you give it a certain amount for too long, then the machine's going to go off.
I agree,
Okay.
but it doesn't mean that it is time stamp. The word time stamp versus a clock that is activated when you press the C-arm and activate the X-ray. I don't know that they're the same clock. There could be a clock that is just simply adding how much total dose of radiation. I agree that such a device exists in the C-arm. I don't know whether that device has anything to do with a timestamp clock. That I don't know.
Well, you were talking about your level of assurance with the diagram of the spinal column. Wouldn't your level of assurance that you're not overdosing your patient with radiation be of much greater comfort if the thing kept an accurate time? You may answer.
Okay, I agree. Again, I'm not a C-arm technician. What's going on in my brain is there may be a timestamp clock. There may be a separate clock that keeps track of the total dose of radiation. That's in my brain. They might not be one and the same clock is my statement.
All right. Well, let's back to the policy. It doesn't say anything about the number of clocks. The way it reads is all equipment should be checked and tested for proper safety and functioning. Do you see that?
I do.
Without knowing how many clocks are in that machine, you agree the ability to keep time is part of the machine's functioning, right?
Yeah, a machine should be able to keep time, yes.
Right, and it's also part of, it's for patient safety, because if your procedure on June 9th went from 10:24 to 10:34, and this film is labeled 9:59, doesn't that create a concern for you?
So my answer, okay, where am I at? Do I acknowledge you and say
Well, I want
yes?
an answer to my question, then you
Okay,
can
right,
explain.
tell me again your question and I'll answer it.
Sure, she can read it back. Please, Madam Court Reporter.
Question, right? And it's also part of, it's for patient safety, because if your procedure on June 9th went from 10:24 to 10:34, and this film is labeled 10:59, doesn't that create a concern for you?
9:59, I apologize.
Not necessarily.
Okay. And
Can I answer now?
does that have anything to do with you and OrthoAtlanta having been sued?
No, I was going to answer the question if I have a chance.
All right,
Okay, so.
Have a
this
chance.
it- Sorry.
you have your chance.
Great. Okay, so this is a list of policy and procedure. As I explained to you previously, to do the best possible job, we set up redundant systems. And you were showing me a picture of the image that was captured on the date of the procedure, and we had discussion, and I said, look at the information to the upper left, look at the information to the upper right. I said, I trust the information to the upper left because that is what's manually inputted by our staff. It matches with everything that was in the medical record. And I said to you, the information to the top right was the machine information. We went over this.
So
So
the Lee
Sorry?
with 3 E's was in the top or left, right? Top, upper left. Your
So
name's
those-
got 2 E's,
yes.
right?
agreed.
And it
So
had 3
I'm
E's,
letting,
right?
no, it does not, and you are correct. All I'm saying is that above and beyond this list that you show me, we have multiple checks and balances in place. That's the only point I'm trying to make.
Okay. And
Yeah.
you also, I'm sorry.
I said yes. I said yes.
And you also have someone come in to check this equipment on at least a monthly basis to ensure that it's working accurately, right?
I don't know the maintenance schedule. I'm not
Uh,
aware.
It reads here, prior to commencement of the daily operative schedule, all equipment should be checked and tested for proper safety and functioning, right?
Mhm. It does read there. It does
And
read.
you agree that however many timekeepers are in this machine, whether it's one or more, and I'm assuming it's one, that's part of the functioning of the machine, right?
I would agree that it is a function of the machine, but it's not a critical safety function. If in other words, if the C-arm picture was faded or incomplete, the procedure would stop. This C-arm is not properly working. Let's get another one in here. And then the procedure would either be canceled or we could place another C-arm. But a critical function of the C-arm is to provide an accurate real-time picture that I'm comfortable with so I can do the procedure.
Right. And the real time would include the accurate time, right?
That's true. Real time is accurate time.
And knowing that Orlena Addison's procedure occurred between 10:24 and 10:34, the time stamp on the film that you gave us, while it's got her name on it, it didn't happen between 10:24 and 10:34. How can you be sure that's a picture of her?
Maybe definitively I cannot, but you showed me 3 or 4 other pictures and you pointed out one spelled Lee with 3 E's, but those I have high confidence. I certainly can't swear to, hey, picture number 1, 2, 3. Can you swear under oath that those are pictures of her? And, equally, I rely on the picture as well as my memory. The other pictures you showed me seem to be accurate, and I had no concern for those, nor do I have concern for the fourth picture. It came from the same surgical center. The same policy and procedure was in place for all 4 events. So I don't have any concern for, what did you say? The authenticity or accuracy, use some term like that, for the fourth picture. I don't have any concern for any of the 4 pictures, sir.
Well, there's a critical difference, though. Those first 3, those timestamps all occurred within the procedure time, according to the record. The fourth one did not. You see the distinction, right, between the 3 that have the timestamp that's within the window and the 1 that does not, right?
Yes, I do see the distinction,
Okay.
but
Go ahead. Yeah.
oh, so again, I say to you, without you worrying about internal clocks and such, it could simply be that the timestamp clock was off, that the C-arm was appropriately functioning, and I deemed it to deliver a accurate, detailed picture for which I could proceed with my procedure. And I went on to say I was increased confidence because the information to the top left matched the procedure note. I went on to testify to that.
And it could also be a different patient, right, with the wrong name on it. Let me answer.
I have no idea.
Okay. And I don't know if you recall, the lower left of that film has a numeral 2 in it. And it's our understanding that you said save only this one, even though there was also a photo number 1. Do you recall that?
No, what I said is it's customary in my practice to take the best photo. So there are times when a C-arm will be used and, take that picture, that's the picture, save that picture. That is customary to me. So
Okay.
that is very customary to all practitioners. As we advance the needle, pictures are taken and save that picture. And it might not have been the first picture. That's what I was trying to explain to you.
Thank you. And so the reason you only saved the 1 is you thought that was the best picture. Is that right?
The best in terms of it being in the accurate location prior to the injection. We take multiple pictures as the needle in real time is, you had that very nice diagram, and then it had the needle going through all the different structures until it gets to the proper structure. Well, the needle, as it traverses, x-rays are taken piece by piece as you get to that structure. And
Yes, sir.
when you get to the structure, that's the correct picture, not the best picture, but the correct picture is the one that's saved. That would be my statement.
Back to exhibit. This is 15, Madam Court Reporter?
This one is 16.
16, thank you. Exhibit 16, the policy CL 21.0. Policy 1A, prior to each surgical procedure, and Arlena Addison on June 9, 2022, that was a surgical procedure, right?
Yes,
The OR, and that's a procedure room in this case, right?
yes,
Staff will prepare each room with the following minimal equipment. 14, other equipment deemed necessary by procedure. Other equipment used for the day, i.e. x-ray equipment. You agree a C-arm is x-ray equipment, right?
I do agree.
Will be tested by personnel prior to being put into use for patient care. Do you see that?
I see the statement.
Okay. Well, that's not just a statement, that's a policy that you're
Okay.
required to follow, right?
Yes,
And you being ultimately responsible for your patient, you're required to ensure that your colleagues, other healthcare providers, follow the policies and procedures there at OrthoAtlanta Surgical Center, right?
Yes,
OR team responsibilities will check to verify that equipment is functional prior to placing patient on the operating table. In other words, before Arlena Addison went on the operating table, you and your colleagues were required to verify that the C-arm was functioning, right?
it was functioning as there were patients before and after her who had procedures, and it did exactly what it was supposed to do to allow for the procedure to be completed. The machine was functioning.
And all those would be included in a daily log for that machine, right?
I wouldn't know that answer. If a daily log is created, I would not know.
OR team responsibilities, equipment that is not functioning properly must be removed from the nursing area, tagged and reported to the administrator. Do you see that?
I do.
Utilizing the surgical procedure and the surgeon's preference card will assemble all equipment and supplies required for the procedure. That includes a C-arm, right?
Yes.
Show you what's been previously marked as Exhibit 17. This is another policy and procedure. This is CL 33.0 radiologic interpretation. Do you see that?
I do.
You've seen this before?
I have recollection.
Okay. C-arm images will be interpreted during a procedure by the attending surgeon who has been privileged for interpretation. That's you.
Yes.
If a hard copy or digital image is printed, it will be maintained on the patient's medical record according to the center's medical record policies and procedures, right?
Yes.
A written signed report of each x-ray shall be made a part of the patient's record if read by the radiologist. Request for x-ray examination shall contain a concise statement of the reason for the examination. Do you see that?
I do.
Was this film ever read by a radiologist, to your knowledge?
No, just by myself.
Okay. Written reports will be provided to OASCA. And what is OASCA?
OrthoAtlanta Surgical Center of Austell.
Within 48 hours and made part of the patient's permanent clinical record. All right. You agree with that policy?
I
That's
do.
existent, and that was in existence in June 2022. If you know.
I don't know.
Okay. Show you what's been previously marked as Exhibit 18. This is policy CL 38. This is objectives of post-anesthesia care unit to establish objectives and goals for PACU in delivering the highest quality of professional care to patients. You've seen that before.
Not this particular one, sorry.
It's all right. You would agree it requires in part to provide appropriately trained and skilled personnel for the delivery of patient care while observing for post-anesthetic and or post-surgical complications. You see that?
I do see that.
You agree that Arlena Addison on June 9, 2022 had a post-surgical complication?
I do agree with that.
Goes on to read, to continuously assess the physical status of the patient through monitoring of airway, vital signs, level of consciousness, surgical site dressings, intake and output, and drainage. You agree with that as well?
I would agree that that is a broad statement for which it doesn't apply to every single case that goes through that center, particularly in terms of things such as intake and output and drainage. There is not a whole lot of intake, output, and drainage going on at epidurals, nor are there, well, surgical site dressing would be a Band-Aid, so, yeah.
Goals of the post-anesthesia care unit are as follows. The post-anesthesia care unit, parenthetically PACU, is a short-term acute care unit whose purpose is to monitor and observe patients during the immediate recovery period following administration of anesthetics. You see that?
I do see that.
In the immediate recovery period for a patient that was minimally sedated, as you suggested, with doses of Versed and fentanyl would be how long?
30 minutes.
So had she not exhibited the decerebrate posturing, the loss of bladder control, the facial droop, the numbness, tingling in the legs, the hemiparesis on the left side, you would have kept her there 30 minutes anyway, right?
Yes.
And you would have let her go. She would have been discharged.
She would have had a thorough evaluation, and if she did not make complaints by taking a careful history, hey, how are you doing after the procedure? I'm doing fine. This is what do we hypothetical. If she's doing fine, are you sure you're doing great? And she's, hey, let me see you turn your neck. Let me see you move your arms. Let me see you move your legs. Can you stand up okay? These are all the safety measures that are taken, screening measures. And if the patient has no complaints and they are physically the same as when they came in, at 30 minutes, they would appropriately be discharged, yes.
And a patient that suffered a severe complication with potential signs and symptoms of a severe brain injury that required critical care was kept in the PACU for 56 minutes, right?
The timing is correct, but there was continuous high-level medical care, at which time, within 30 minutes, EMS was activated and EMS came. And in this particular case, the patient continued to improve to the point to go to the hospital. But to your point, because as a clinician, I have the care, the concern, and witnessed in total everything that happened, then I strongly suggest that she go to the hospital. So yes, you read me policies, procedures, and showed me timelines of 30 minutes. But my response is, in the real world, it depends on what's happening with the patient, if that makes sense.
Arlena Addison's not the doctor, right?
No, I'm the doctor and I decide. And again, I tell you that in the first 30 minutes, she was getting continuous high quality medical care as documented by high flow oxygen, attempt to get EKG, continuous monitoring of vital signs, having anesthesiologist present, having CCU nurse present. And because things persisted at approximately the 30-minute mark, EMS was activated. If it took EMS however many minutes to come and then do their own assessment and pack her up for transport, if the total time elapsed was 56 minutes, then that's what occurred in real time.
I'll show you what's been previously marked as Exhibit 19. Policy number CL 39.0, patient care, PACU 1 and 2. I'm going to scroll down to page 3 of 4. You see that? Criteria for transfer from phase 1 PACU to phase two PACU or direct admission to phase 2 from OR? Do you have
I
both
see.
a phase 1 and a phase 2 PACU?
I don't think that applies to procedural interventions. That may apply to surgical interventions that are more complicated and require anesthesia of a more robust sort, like an anesthesiologist providing mask or ventilator or stronger medications.
Are you aware of a phase 2 PACU at the OrthoAtlanta Surgery Center in Austell?
No,
You agree that a phase 2 PACU provides a higher level of care than a phase 1 PACU? You may answer.
no, I'm not aware.
Okay. Show you what's been previously marked as Exhibit 20 to your deposition. This is policy number CL 46, which is transferred to tertiary care facility.
I see that.
We started to go over this earlier. The policy, it is recognized that it may be necessary to transfer a patient to a tertiary care facility for acute care services and or an overnight admission that is not offered within the center.
I see that.
And by within the center, that's OrthoAtlanta Surgery Center, Austell, right?
Agree.
Procedure. Personnel should always anticipate the potential for an unplanned transfer to a tertiary care facility of a patient is experiencing unusual problems or complications, right?
I see that. I agree.
And you agree that Arlena Addison on June 9th, 2022 was experiencing unusual problems or
I
complications.
agree.
Tertiary care, unplanned admission form should be obtained. That's the form we reviewed earlier.
I agree.
When the physician makes a determination to transfer the patient, the administrator or designee will initiate the process for the transfer and make assignments. Remember anything like that happening?
Yes,
Okay. Emergency, do you see this? Call 911 and explain that you have an emergency transfer to Wellstar Cobb Hospital and provide a brief description of the patient's condition. You overheard that earlier, the 911 call, right?
yes, I think the 911 call meets that provision.
Okay.
Call 911. Yeah, there a 911 call was made. Yes,
Provide a brief description of the patient's condition.
yes,
3, the hospital will be contacted, emergency room, and a report given to the appropriate person.
yes.
Did you, I believe you said you spoke with someone at the hospital. I did ask you whether you'd contacted the physician in charge, and you said you had not, right?
Agreed.
The attending physician surgeon will provide a direct report to the ER physician. If not feasible, the physician surgeon should consider the ER physician or accepting physician once a patient leaves the center.
I see that.
Okay, and that didn't happen in this case, right?
I don't believe it did.
Copy medical records using the form as a guide, document exactly what is copied to send with the patient to the tertiary care facility. You agree with that as well?
I see that as a statement. I agree that's part of the procedure.
But the only thing that went with Arlena Addison was your note, right?
I'm not aware of all the records that were sent.
Okay, are you aware of any record that was sent other than your operative note?
I don't know if other additional records were sent. I don't know.
Well, it also says you are required to record in Arlena Addison's medical record what was sent, right?
Copy medical record using the form as guide. I don't know what form, so I didn't use the
I'm
form.
talking about this part, document exactly what is copied to send with the patient to the tertiary care facility. Do you see that?
Yes, I do see that. Document what was copied. So if nothing is documented, then I don't think there was anything that was copied to send.
Okay. When emergency medical service personnel arrive, a report will be communicated by the person who has consistent and ongoing knowledge of the situation and treatment, a physician, PACU nurse, that'd be you or the PACU nurse, right?
That's right.
Document status of case, care of patient immediately before transfer. That was done, right?
Yes,
Communicate with family, significant others, the status of the patient and what they should do.
yes, that was done.
After the patient leaves the center, review the situation immediately with the personnel that were involved in the patient care scenario and ensure that everything is documented, right?
Yes,
Was that the purpose of that? I think you called it round
team
table.
huddle. Yeah, like a team
Team
huddle.
huddle.
Yeah, yes.
This is the next page. Contact the receiving facility. We've been through that. And you didn't speak with the ambulance driver, right?
I did. The EMS that came into the PACU area, I spoke with them and told them of the circumstances as well. I personally spoke with them. Yes,
Do you remember whether it was male or female and how many?
I don't recall. I'm sorry.
Show you what's been previously marked as Exhibit 21. This is a portion of the audit trail where you viewed or changed the medical record. Do you recall making any changes to the medical record?
None.
Okay. Page 1 of 22 of exhibit, is it 20, Madam Court Reporter?
21.
21, thank you. This is, you see where it reads 114 of 192?
Yes,
Arlena Addison. 6/9/2022.
Uh-huh,
Yong Lee, that's you.
that's me.
And it modified the face sheet. What
I
is,
don't know how to do that. I don't know how to modify a face sheet.
okay, so that's inaccurate.
No, I don't know how to, I know how to get into the EMR, the electronic medical records, to create progress notes. A face sheet is a different thing altogether. I don't know how to do that.
All right,
A
so
face
you're,
sheet is a example like the patient's demographics, insurance information, things like that.
so you didn't do that, right?
Cannot come up with a reason to in any way modify a face sheet. That's is that what the audit trail shows, the face sheet?
Well, yes, this is audit trail.
Agreed, but my only statement is I don't even know where a face sheet is located in our EMR. I have no use for that.
Okay. This is when you created your note, is that right?
Uh-huh.
That's where it reads medical reconciliation.
That timing is day of procedure and the time is 11, what, sir?
11/13/05.
That may be me signing off on meds or something. If they're talking about medication reconciliation.
Okay. Still on June 9, 2022. Op note modified. Did you modify your op note after you created it?
I did. The original office note is the first part of the note. That second statement is the modified part where the first part of the note, I don't know where the audit trail shows it was created, but that is a templated note. And because the patient had this unexpected outcome, I did type in the second part of the note. That's what I think that is.
Okay.
Because the time frame is in the 11 something. What is the time frame of the modification?
Depends on which one you're looking at, but 11/12, 11/11.
That would be the part where if you look at the operative note, the second portion where I detail exactly what happened, that is the audit trail that's occurring right
Two
now.
paragraphs, right?
Uh-huh.
Okay.
Yes.
Operative. Owner's been assigned, that's you, right?
Uh-huh. Yes.
Then you signed the note. So then you completed the note when you signed it, right?
Right.
That looks like, let's see. And where it reads op note unsigned, are you prompted to sign an operative note?
I think that is what prompts me to sign a note when I see something like that. If I see a sign like that, I will sign it. Yes.
This is still 6/9/2022, the op note,
Uh-huh. Yeah.
Before you-
Yes.
all before you'd signed it, right?
Yes.
Now, do you save a preoperative work list?
I don't know what that is.
Okay. So the answer is you did not, right?
I don't know what a preoperative work list is. I'm sorry. I don't even know that term.
So what's been previously marked as Exhibit 22? It's a portion of the audit trail. This is page 52 of 192. See where it reads 6/16/2022, Arlena
I
Addison?
do.
That's a week after the procedure, right?
Yes,
Procedure was on 6/9/2022. This was deleted. You see that?
I do see the word.
And that reads,
It's a different patient.
okay.
That is a completely different patient.
Hey, James, so we don't
Yep.
have to send emails to Bonnie later. Can we just agree on the record to redact that name from the transcript and or the exhibit?
Sure.
And Bonnie, if your office can just, black out that name so we don't violate HIPAA somehow with another patient's name. That's how we've handled this in the prior depositions.
Yeah, that's fine.
I'll let them know.
Thank you, Bonnie. Do you use the Epic system as well, right?
We had transitioned from one to the other, and we do use the Epic system.
And you make records in the Epic system?
I do.
And you made records in the Epic system regarding Arlena Addison?
I may have.
And those are not part of the patient record, is that right?
They should be. She's still a patient loaded into our system. Just because we switch EMRs doesn't mean that she doesn't still have an official patient record with us. That counts as an official patient record.
Okay. Have you ever had your ability to prescribe medicine curtailed in any way?
No,
Show you what's been previously marked as, are we 2022,
23.
23? Thank you. Show you what's been marked as Exhibit 23. You ever seen this before?
I'd like a minute to read it.
Sure. I'm gonna scroll down to your portion. Will that help?
Yeah, that helps.
Okay.
So that appears to be a medical record through our EMR, probably from the new EMR system, I'm guessing. I don't know. It doesn't actually name the EMR system. But in
Okay.
either case, the top part of the record is from my medical assistant who fielded a call and did her documentation. And then when I responded to the call and talked with the patient face to face as part of thorough medical documentation, I documented the telephone conversation that I had with the patient using the office phone.
All right. And it reads here, author is you, Young Lee, MD. And am I pronounced, is it Young or Yong or
It's the second. There's no U in my name, so it's the second.
Yong? Thank you.
Correct. Okay.
Right.
Thanks for asking.
Yes, sir. It filed 6/23/2022, so this is a couple of weeks after the surgery, right? After the cervical epidural, right?
Yes, it is.
Says you reached out to Arlena Addison. I expressed my concern for her health and full recovery. She thanked me for insisting that she go to the emergency room for further evaluation after having complications from her cervical epidural 2 weeks ago. She informed me that she was hospitalized from Thursday afternoon through Sunday morning. In the hospital, she had a series of CT scans of the brain. She was told that she suffered a seizure and stroke. Do you see that?
I do. These are the conversations that we had, and I did document in real time. So that's
Right.
pretty close.
Well, she was attended by a neurosurgeon, cardiologist, and neurologist. She has still experienced headache, brain fog, and left-sided weakness. You see that?
These are her reports to me. Yes, I
Yeah, any
fully
reason
documented.
that she was lying or being dishonest in any way?
No, I have no reason, but I didn't examine her, but this is our phone conversation. Yes.
Yes, sir. And it also comports with, it's certainly reasonable for a patient with a clinical history that she had and that exhibited the signs and symptoms that she did to have an ongoing cognitive impairment, right?
This is outside the scope of my expertise, but I am documenting in the note. I had a conversation, and these are her reports to me, and I have no suspicion that she would not be reporting to me accurately.
She was told this was attributable to the stroke she had. Functionally, she reports requiring use of a cane to ambulate.
Mhm,
Time of discharge, she was given orders to attend physical therapy.
mhm,
She is living in Carrollton, Georgia with her daughter. She is in need of refill of her pain medications due to the weakness of her leg and her gait instability. She cannot make it into the office. You see that?
mhm. I do.
She's aware of the closing of the office in Hiram. The new office in Cartersville, Georgia is distance prohibitive for her to continue care. She is requesting names and numbers of alternate pain practices to ensure continuity of care. Additional 2 months supply of her baseline pain medications will be provided. She expressed desire to avoid further epidurals in the future.
Mhm.
See that?
I do see that.
She is told that she has a moderate to large cervical herniated disc, and as long as she remains neurologically intact, that pain medication remain of therapeutic value. Additional epidurals would be on an elected basis. Electronic
Yes.
Yong S. Lee, June 23.
Yes.
Here's another one. This is June 10th, right? This is a day after the surgery.
Uh-huh.
Day after
Yeah.
well, the surgery because you go through the skin, is that right? But it's an epidural injection.
Yeah. Yes.
Electronically signed by Yong S. Lee on 6/10.
Yes.
Patient had complications from cervical epidural steroid injection performed yesterday, June 9th. Patient was taken by ambulance to Cobwell Star, attempted to contact daughter on June 9th, got voicemail with message, mailbox is full. Second call was placed June 10, again, voicemail full, cannot accept messages. Called the patient's room and spoke with daughter Hillary. Daughter tells me mother's doing okay. Mother's currently out of the room undergoing some additional testing. Daughter tells me that her mother's under the care of a neurosurgeon and cardiologist. Neurosurgeon is treating the patient for hemorrhagic stroke. You see that? Well,
I do see that.
you recall, these are your notes based on the contact?
Based on the conversation, yes.
Right. Treated the patient for hemorrhagic stroke and has ordered for serial CT scans to monitor the bleed. Cardiologist continues to run tests. You see that?
I see all that. I do.
Any reason to believe that she was being inaccurate or dishonest in any way?
No, none. But inaccurate, I don't know the accuracy of a layperson. But if those are the statements that she relayed to me, I feel that I accurately expressed them in the notes.
I expressed care and concern to the daughter regarding mother's health. I provided daughter with my personal cell phone and asked her daughter to express my concern and wishes for recovery and good health. Daughter will talk to mother and a later time, if circumstances permit, she can call at her convenience. You see that?
I do see that.
And this accurately reflects everything you recall about the conversation, right?
Because it was contemporaneously documented. It would improve the accuracy. Yes.
It's going through my notes, Doctor. We're not gonna recover anything. Have you ever been issued a subpoena?
Subpoena, can you tell me what that is?
Someone that sends you a document that requires you to appear?
Yes.
Okay, and what was the nature of the subpoena you were issued?
It was regarding opioid prescribing as related to the recent prescription drug epidemic. I think at that time, if I'm not mistaken, the state's attorney generals were suing the pharmaceutical industry, and they were taking testimony from doctors who have been prescribing opioids as part of their practice.
And you were subpoenaed to testify?
I think so. I mean, I did have a phone call, I mean, a televisit like this, a Zoom visit.
Okay. Were you under oath?
Yes,
Okay. And do you remember when that was?
2 years ago, 3 years ago.
So roughly 2021, 22, something like that?
Yes, yes.
And that was a meeting with the attorney general, you think, regarding prescription drug?
No, it was, the best I can remember, it was the state's attorneys general were suing the pharmaceutical industry. Georgia was one of the states, and Cobb County, there was a attorney that interviewed me.
Okay. And when you start your day at OrthoAtlanta and Austell, what time did you start in the morning?
My schedule has changed since 2022. So the typical start time would be 7:30, 8 o'clock.
Okay. And you would work until what time?
Depending on the number of cases up until noon, I'm blocked off for that from like 8 to noon.
So 7:30 till noon?
Is the block time, yes, but
And
not,
how many days per week?
at that time, it might have been every other week or once a week.
Okay, 1 day per week?
Yes,
1 day every other week. And how many patients did you see in an hour? Was it every 10, 15 minutes? When was?
Each procedure requires a different block of time, so it's variable.
You remember
Some
how?
procedures are more time involved and other procedures are less time involved, but averaging 3 per hour would be reasonable.
Okay. And were you paid per patient or for the block of time? How did that work?
I think it's based on productivity, sir, not per patient or per time. It's productivity.
Well, productivity would be per the number of patients.
Different patients require different procedures, so each one has a different productivity value. Does that make
The
sense?
billing codes, the more you
Right.
bill. Got it.
They're different.
Did you refer any patients out before or after you were subpoenaed by the attorneys general?
I have reduced my profile in my practice such that prescribing opioids is less a part of my practice. Yes.
And why is it less a part of your practice?
Well, because of the inquiry, and I just chose to lessen the number of patients that would use those type of medications.
Tell me what the nature of the inquiry was. Was that, were you being investigated regarding the, okay, what was the
No,
nature?
the best I can tell, it was Cobb County, and it was an attorney from Cobb County who interviewed me and asked me about my practice style. It was a one-time interview and nothing came of it. So I don't know the nature. I don't know the nature of it.
So you mean it was a district attorney in Cobb County, not an
I
attorney?
think so. I think so, district.
You use fluoroscopy on a lumbar epidural steroid as injection as well?
I do.
I believe this Addison was on a Thursday. Was that normally the days you worked in 2022? Or did it vary? How'd that work? Thursday?
Thursdays
Okay, always Thursday.
is part of my schedule.
Got it. Do you know what happened to the image one? Was that just discarded?
I don't think okay, the word discarded. If it's not saved, then it was never saved to be discarded. Again, I tell you, image 1 or 2 or 3 as I inject, save that one. So it's not like the computer stores the images, it will store the image that I say that's the correct image to store. This is the correct image, and it stored that image. I don't know that there was a preceding image that was ever stored.
Sure. Otherwise, the image, when the buttons hit, the image that's stored is overwritten somehow. Is that right?
I think so, yeah.
You do the same thing in a lumbar epidural? Save
I have the same technique.
Yes, sir. What's your understanding about why those weren't produced in this case?
No idea.
Okay. Any reason to believe that those were destroyed or?
No, none whatsoever.
And would those, like the ones that were produced 16, 19, the lumbar would go back that far as well?
Every time we use fluoro equipment, that equipment is supposed to be capable of saving images.
Okay. Well, they're also saved to the patient's file, right?
Yes,
Okay. And the lumbar pictures are also taken with a CR.
yes.
Same procedure room.
Not necessarily. There's another procedure room in the office that has a C-arm, but it's not the same procedure room.
Also there in the surgery center, Austell.
In the Austell building, the upstairs of the building are clinic offices, and there is a procedural room there.
That not where Addison was on June 9th, though.
No, she was in our surgical center.
Got it. All right, that's all I have. You be safe.
I've got just a couple of questions.
I'm listening.
Can you hear me? Sorry, I haven't been talking,
Hear
so I
you.
don't know how well my microphone's working.
It works.
Okay, Dr. Lee, I represent Piedmont Orthopedics and Piedmont Healthcare. I promise I'm only going to ask a couple of questions. We have all been here long enough. I believe you testified earlier that you were not employed by Piedmont Orthopedics in June of 2022. Is that correct?
I believe that's what I said.
Okay. Is that also correct that you were not employed by them at that time?
Yes,
Okay. And what about Piedmont Healthcare? Were you employed by Piedmont Healthcare in June of 2022?
no,
Okay. I know you mentioned a physician services agreement. In June of 2022, had you personally entered into any contracts with Piedmont Orthopedics?
no,
What about Piedmont Healthcare?
no.
Okay, that's all my questions. Thank you.
Thank you.
James, anything else?
No.
All right, we're done. Bonnie, I'll take an E-tran with a PDF of the exhibits. And we'd like to read and sign.
Hey, Bonnie, since we marked on those exhibits, I mean, the photos especially, can you save that from where we uploaded it? I mean, I saved those as we went, but I want to make sure that the exhibits accurately reflect what happened. Does that make sense?
You're on mute, Bonnie.
I understand what you're saying. I downloaded the exhibits when you put them in the chat, so I don't have any of the marks on mine. So you would have had to save them again once you marked them.
Yeah, we'll get you. I think it's just the just those films, right?
Right.
I assume we have them. I mean, worst case, I guess we've got them in the video, but
Yeah, I was gonna say it's all recorded.
okay. All right, that's all I have. Thank you.
All right, and Olivia, are you ordering a copy?
I am gonna order an E-tram, please.
All right, and 1 second. We're going off the record at 4:46 p.m.